So please start in 3, 2, 1. Please start, sir. We are live.
Okay, so good evening, everyone, once again. And we had a very good session yesterday, which was mainly focused on breast cancer, both early as well as metastatic setting. Predominant discussion was on HER2 positive as well as HR positive disease. Regarding TNBC, there was limited discussion, only I think one positive discussion about adjuvant role of platinums post-surgery in high-risk TNBC. So that was discussed, and we shift the focus from breast cancer to lung cancer, and also a few topics from GU, predominantly a panel discussion on endometrial, one on ovarian, and a talk on a newer antibody drug conjugate, which is now available in Fortumab. So we will discuss about that. To begin the proceedings today, we have Dr. Arkadev from BARD clinical team, and he will be discussing about the newer device, the PIC line device, which has um unique, which is a unique device where the tip of the device basically can be confirmed by ECG, because that is something which gives us problem as to confirm the exact location of the device, so that it does not cause any other complications. So he'll be discussing. I understand that it is better if we have a hands-on or direct visual demonstration of such a presentation, but I think just to get an idea, and then maybe at some later time we will organize a physical session also at our center. So with that, we will start. Over to you, Dr. Ghosh.
Thank you very much, sir. Hello, I'm Dr. Arkodev Ghosh. I'm a pediatric by profession. So I'm associated with the BD team currently. And today we will be discussing regarding a newer technology in ECG-based PICC line tip confirmation system, which was present in Western world, but we have launched the system in India very recently. So I'm sharing my PPT. Okay. My screen is visible. Hello.
No. No.
Just 1 minute. Share. Okay. Now is it visible?
Yes.
Okay. Thank you very much. So this is the future of PICC line placement and the tip confirmation system. So in this presentation, we will be knowing the current practice of PICC insertion, where the tip is located. We will confirm that. And obviously, with this method or with this technology, we can reduce the time of insertion, the duration of process, difficulties in insertion or the malposition complications, and we can start the therapy as early as possible. So, in recent guidelines, if we are using any vesicant drug or irritant drug, we can use the PICC line at the very beginning of the therapy when the therapy is of more than 6 days to 1 month duration also. Basically, we prefer PICC in those areas where the therapy duration is more than 1 month to up to 1 year of duration. So while we are inserting a PICC line, the PICC line is placed via USG guidance. USG guidance means the vein is located via the USG or the blind insertion. Sometimes we go for this also. Then we take the exact measurement, we insert the catheter, then we go for an X-ray confirmation for the tip position. And if there is any problem, we have to remove the catheter or manipulate the catheter for proper tip position. Sometimes it may go to the jugular, sometimes it may get coiled within the vena cava itself. So it takes nearly 3 hours to initiate the therapy. So in this system, we will first calculate the exact length of the catheter. So if this is the point of insertion, from point of insertion to the suprasternal notch over the shoulder, and then from the suprasternal notch to the third intercostal space of the right side, we'll take the exact measurement after the puncture is being done. We can do the puncture via USG guidance, or we can go for it as a blind procedure. So we puncture the vessel, insert the guide wire, and with the help of the guide wire, we will insert the dilator and sheath. This part is exactly same, just like the before. Now we will trim the catheter at its exact location, as it's a special type of catheter is being used. This is called Power Pick Solo. So we will cut the catheter. The tip of the catheter, or not saying the catheter, the tip of the stellate has a magnetic flip over it, and we will place a device. This is called the Y sensor. This Y sensor will help us. So this is the Y sensor. The Y, the notch of this device will reside over patient's chest. It will correspond to the suprasternal notch of the patient. So this will be placed in patient's chest. There will be two electrical leads attached with it, one at the right subclavicular region and one in the left mid-axillary line. So this device will make the heart in the midpoint of an electrical rhythm, and that will show the patient's normal baseline ECG. And with that catheter, the catheter is also attached with this device, and then the catheter itself will create a intravascular ECG. That intravascular ECG can be seen while we are inserting the catheter inside the vena cava. So I'm showing just a small demo how it actually looks like. So whenever the catheter will insert within the patient's body, the white one is the patient's baseline ECG. Whenever the catheter will get inside the patient's vena cava, the P wave will start rising. And one particular time or at particular junction, the P wave will be the maximum. The maximum P wave will be colored as green P, and the catheter will be here as a cursor will show as a green diamond. So first of all, we will check the patient's baseline ECG. We can actually confirm it very well. If there is any atrial fibrillation or ventricular tachycardia, that will be unreliable. So passing the axillary, then the subclavian, this machine will start recording the elevated P wave on its own. We don't have to do anything. And whenever it will reach the cavatrial junction, the P wave will be the maximum. And the maximum P wave will be denoted as a green P. So whenever we will see the green P or the max P wave, that is the cavatrial junction. And at that position, we will keep the catheter. We don't have to go for an X-ray confirmation, or we don't need to go for other confirmation system for this. So this is basically a magnetic device with a software technology that will show us how the catheter is moving. If there is any coiling, the ECG lead will be changed. If there is any uh, dislodgement or the catheter goes to the jugular also, that machine will show where the catheter is actually going. So it's a real life tracking, just like a GPS. So ideally, the tip should be positioned at the cavatrial junction as it got the maximum high or the highest blood flow rate, and the catheter is parallel to the vessel wall. It is not going to irritate any of the cardiac chambers. the turbulence is very high, so there will be very little chance of thrombus formation and there will be very little chance of malposition. So with this method, we have a database over thousands of patients, and we are trying to insert the catheter in zone A. The zone A is the perfect area or the lower one third of the superior vena cava or the cavaitral junction. With this system, we can actually place the catheter with 98% accuracy in this PICC line placement. And the most advantageous position is this Sherlock 360 system have combination of ECG-based reading, magnetic tip confirmation, and also we don't need for regularly day-to-day X-ray confirmation. We can avoid the radiation exposure also. And only in 2 to 3 cases where there is atrial fibrillation, where the P wave is not very prominent, or the patients have multiple jerky P wave or the ventricular tachycardia, in those cases, this system will be not reliable. But also we can actually navigate where the catheter is going. So the green diamond or the green stylet color is the indicator of its perfect position. So whenever we will get inside the atria, the P will be inverted, the P will be biphasic, and then we can actually understand that we are actually within the heart itself. We will pull out a few centimeters and we will wait for the maximum P wave or the green diamond, and rest everything is done. We will just place the catheter at that position. We will fix the catheter and we will start the therapy as soon as possible. So after tip confirmation with the Sherlock and after with the same patient will given with an X-ray, and it is showing at the cavaitral junction or the lower one third of the superior vena cava. This is how we actually measure how accurate the system is actually. So obviously it is a gold standard. Visual information, reduce the risk of transportation, decrease the time. There is no blind method. If there is any kink or coiling, that can also be seen via this method. And not only this Sherlock system, we have introduced a new type of catheter. This is called the Power PICC Solo. Solo means saline only, lock optional. So previously we had Power PICC, the open-ended catheter, and there was chances of thrombus formation spontaneously within the catheter itself. Now we have the valved catheter where the valve is present at the proximal part of the catheter. So there will be no spontaneous blood indrawn within the vessel itself. We can use both the lumen or triple lumen or single lumen. This is power injectable, multiple drugs, multiple therapy can be given. We can use the contrast media via this catheter, and also for the patients who are thrombocytopenic, we don't require to flush the catheter with heparin again and again. So it's a win-win situation for all of us. So the valve property from the Grosjean and the power injectable property from the PowerPick both have been conjugated in one single catheter where only weekly flush is enough. Heparin is not required, and obviously it is power injectable. CVP monitoring can be done, and all the medications can be given via this catheter. So it is a set or a system where we are giving or we are providing a better catheter for your day-to-day usage in oncology. And this catheter can also be tracked down via a real-life GPS-like tracking device where you can actually trace where the catheter is going, if there is any malposition or not. And if there is any malposition, you can check it and you can correct it on the spot also. So the average duration of placement of catheter will be decreased. There will be no malposition. No catheter will go to the jugular. And obviously, the longevity of the catheter will rise to a very high extent. So, to summarize, we are at a place or at a pace to show कि X-ray is not the gold standard for tip confirmation. We have another type of device which is not in which the X-ray is not required, and obviously this catheter is beneficial for all of you. And over a period of time, we have seen it's 97 to 100% accurate on a single shot to insert the PICC line and to confirm the tip position. Thank you very much.
Thank you very much, Dr. Ghosh. This looks quite good. So, what is the extra cost?
The PICC line is exactly same, just like the power PICC. It is maybe 1,000 rupees costlier than the power PICC on its variant. And the machine, the device comes separately. This is a one-time investment. I exactly don't know how it will cost in India right now because there is a GST transformation and other things. So somehow it will be around 8 to 10 lakh
For the device, for the
for the
monitor,
device.
and plus this
Uh,
Y.
the voice sensor monitor, there will be a another printer that will print out the green diamond and the green P wave that can be kept as a medical record with the patient's BHT, and the entire system will come. I exactly don't know after conversion of GST what will take. It will take somewhere around 8 to 10 lakh.
Hmm. All right. So, and this is with the two lumens. This pick line is with the.
No, it got 4 French single lumen, 5 French double lumen, and 6 French triple lumen. All the three configurations are available. You will choose according to your needs, sir.
Okay. Thank you so much. And as I said earlier, I think we will need a physical
Yeah, sure, sir.
demonstration at our site, and then we can work out whether the administration or the hospital will be agreeable to accepting this technology or not. But definitely, I think will be helpful. Thank you very much.
Thank you very much, sir.
So we then move on to the next session. Before we start the lung specific talks, there is one session uh, regarding enfortumab vedotin in relapsed refractory bladder cancer, and for that I would request Dr. Kanupriya Bhatia, who is consultant medical oncologist at Oswal Hospital, to give the talk, please. Thank you.
Good evening, sir. If someone can share my slides, I'll begin with the session.
Vishal, do you have the slides?
Do the organizers have my slide or do I
Yes, sir.
share
Yes,
from
sir.
my
We are
end?
sharing. We are sharing.
Okay, okay. Okay, so good evening and thank you, Dr. Kunal sir and the team for making me a part of this academic event. So the job that I am given today is to discuss enfortumab vedotin in relapsed refractory bladder cancer, which is PADCEV. So I believe this is a molecule which has changed the entire algorithm of bladder cancer. It is one of the molecules which have changed the entire bladder cancer also. So the target here for EV is the Nectin-4, and it has the payload attached to it, which is a microtubule inhibitor, MMAE, which is the chemotherapy that is attached with it, and that is how targetedly this ADC works. So today my job is to discuss the EV301. Next slide, please. This is the disclaimer. Next slide. So locally advanced refractory to the treatment and metastatic urothelial cancers, we know that up to 50% of the patients come to us very late, till when the disease has progressed, their performance status is very poor, or because they are elderly, they have one or the other factors which precludes us from using cisplatin, which used to be the first line therapy in metastatic urothelial cancers. So around 50% are actually not eligible for platin based chemotherapy, and of those whom we are able to give platin, many of them, they actually don't respond to either platin alone or a combination with immunotherapy like nivolumab. And 5%, it is less than 5% that we are able to see a good overall survival. Usually the median overall survival used to be in these cases just slightly above 1 year. Next slide. So EV301, this is the second line and beyond setting that I will be discussing today, where a patient who has already received prior platinum-based chemotherapy, either in the neoadjuvant, adjuvant, or the metastatic setting, and prior exposure to immune checkpoint inhibitor. Next slide. Next slide. Next. Next one. So, like I said, platinum-based chemotherapy and PD-L1 inhibitors used to be the first-line standard of care in metastatic urothelial cancers. Today, the scene has changed. Today, after EV302, a combination of EV and pembrolizumab, if a patient can afford it and has no contraindication to using these agents, the first-line standard of care is actually EV plus pembrolizumab. But because in a setting that actually happens in probably less than 5% of the patients, we end up using platinum-based chemotherapy as our go-to regimen in all patients of metastatic urothelial cancer. So in those patients, the second line agent, that this is EV301, which can be used. Patient survival in metastatic disease, we already know it is poor, and there are limited options to be used in second line. So to answer this question, EV301 was there. And if people might be wondering, why am I discussing 301 when 302, 3 and 4 are already there? It's because in India till now, we only have an approval of 301. And this was one approval which came at the first one for EV, and which is why we'll be discussing this data today. Next slide. So a phase 3 very well conducted randomized control trial with patients who were already exposed to a platinum-based chemotherapy and immune checkpoint inhibitor were randomized into either receiving EV. The dose is 1.25 mg per meter square, day 1, 8, 15 of a 28-day cycle. And the other arm, the patients were randomized according to the physician's choice of chemotherapy, which either included docetaxel, paclitaxel, or vinflulin. The primary endpoint of the trial was overall survival, and the secondary endpoints were progression-free survival, overall response rates, disease control rate, and most importantly, quality of life and safety and tolerability of the drug. Next slide. So the demographics were well matched between the two groups. We see that the median age group is actually the elderly patients. The median age was 68, and around 20% of the patients in both the arms were actually more than 75 years. And around 20% of the patients were pre-diabetic or had a history of hyperglycemic episodes. This is important because as we discuss the side effects of EV Padcev as well. Next slide. So majority of the patients were performance status 1. They were very less for PS2 and no patients with PS3 and 4. Now, what is important to see here is that majority were urothelial and transitional cell or transitional cell carcinomas, though this trial did include patients with other types also, like with sarcoidoid differentiation or with squamous cell differentiation. And around 1/3 of the patients actually had liver metastasis as well. Next slide. So coming on to the curves of overall survival, we see that in second line and beyond setting, using EV as compared to the standard chemotherapy that we were using at that time, the overall survival improves from almost 9 months to 13 months. Next slide. So, because such an improvement was seen, actually EV301 was prematurely stopped after the interim analysis, which was done by Dr. Pauls in 2021. And the results were published in 2021, and the study was not further continued because of the excellent results in at that time, which was seen in second and beyond settings in patients with metastatic. These were results never seen before in this setting. Next slide. So the benefit in the overall survival and the benefit in the progression-free survival that I'll come in my subsequent ones was seen across all the groups, be it any age, and was specifically seen in patients with bad disease also. Those patients who had liver metastasis, they also responded equally beautifully to EV as compared to chemotherapy. Next slide. Again, these are the PFS curves. PFS improved to 5.5 as compared to standard chemotherapy, giving a PFS of around 3.7 months. Next slide. Again, PFS, like I said, was seen across all the groups. Next. So the overall response rate had almost doubled. With chemotherapy, we are seeing ORRs of around 18.6%, and with EV, using EV, the overall response rate had improved to 41%. Next. Next. Again, the benefit in the ORR also was seen in all the subgroups. I will come to the real world setting and the various subgroup analysis, which then tell us that actually the response rates and the benefit was slightly lesser in histologies which are other than the transitional cell histologies. The subsequent slides will come to that. Next slide. So what actually matters to the patient in a metastatic setting, apart from overall survival, is actually quality of life. And we can see the yellow bar, which is actually giving a very inconsistent quality of life. There are dips which are affecting the patient as compared to the blue line, which is of PADCEV, where there's a consistent quality of life. It's not affecting much. So throughout the patients who were in trial, the quality of life did not deteriorate much as compared to chemotherapy with enfortumab vedotin. In fact, symptoms like dysuria and pain improved with time with this drug. Next slide. Next. So like I said, the quality of life was maintained over the first 12 weeks of treatment. It was associated with a significant reduction in pain. And patient who received EV, they had an improvement in all functioning domains and most symptoms domains, including pain, fatigue, and dyspnea. Next slide. Coming on to the side effects, now both chemotherapy and EV, they had numerically similar amount of side effects seen in the patient. But the side effect profile of the two arms was entirely different. Chemotherapy, we all know, like all the other drugs, caused anemia, caused cytopenias, thrombocytopenia, or febrile neutropenia in this population. Whereas the arm A, that is the experimental arm with PADCEV, had a different side effect profile altogether, which we are just now learning how to manage. The most important side effects being peripheral sensory neuropathy, and which is very common with this drug, and which is one, if a patient already has a baseline significant peripheral neuropathy, it is one of the contraindications or one of the cautious signs while we might be thinking of using this drug. The second side effect, which actually bothers the patient a lot, is pruritus with or without the rash. It's a very benign sort of a side effect, but when the patient actually gets affected and comes and sits in front of you and tells you that day and night he's just itching himself and has scratch marks, it's really bothersome for the patient. It also causes dysphagia and causes significant hyperglycemia and sugar derangements in patients. Next slide. Next one. Next. So side effects leading to death were matched in both the arms. Both the drugs caused in some patients multi-organ dysfunctions and hyperglycemia. Next one. The most common causes of doses reduction in PADCEV was peripheral sensory neuropathy, pruritus, a rash, and these were the reasons leading to dose interruption as well. Next slide. So most of the side effects were grade 1, 2, 3, and 4 were very less in the study. Next. Next one. So to summarize, basically from this EV301 trial, median OS in second line and beyond setting in patients who already received a platinum-based chemotherapy and a PD-L1 inhibitor, with using PADCEV, we are increasing the median overall survival from 8.9 to 12.9 months. We are improving the progression-free survival, improving the overall response rates, and the quality of life is not significantly hampered. Next. 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 So this was the trial setting. I do have some slides of the real world data also. In India, we have just started having the experience. These studies are from United States, Japan, and other areas where doctors have started using PADCEV. Next. So this is the Unite registry from US, where around 260 patients in this setting were treated with this EV301 regimen. And overall response rate, like we saw, is around 50%. In fact, real world settings are showing us better progression-free and better overall survival data as compared to the trial itself. And all these studies actually show that the ORRs and the PFS, it is more in pure transitional cell histology as compared to the variant histology. Next. So like I said, urothelial histology, significantly we can see in this table, urothelial histology, the ORR is 58% as compared to variant where the ORR is 48% and the p-value is almost significant here. So maybe the treatment regimen in variant histologies needs to be different. Next. Next. Next slide. Next. Again, this Unite study, it gives the same better PFS and better OS were seen. This is a part, the study is a part of the, again, the Unite registry also. Next slide. Nothing. We can just pass on to the next 3-4 slides. They're very similar. Yeah, just hold on this one. So we can see I want everyone to concentrate on the just last column where we see that in biopsy specimens of bladder cancer which have pure variant histology like squamous or micropapillary or sarcomatoid, the overall response rates with EV in this line setting actually are 0. So it is the variant histologies where we might have to think outside of the box and probably think of chemotherapy. EV is not helping much in these cases. Next slide. Next. So next 2-3 slides, we have data from German and Swiss hospitals also. It's all similar data where EV is showing similar benefit. So this is my last one, which says that efficacy as measured by response rate, PFS and OS is reproducible in the real world settings also, and toxicity as we see in the trial, peripheral sensory neuropathy, hyperglycemia, rash, these are the mains which trouble our patients. Next. I think that's the last one. Thank you.
Yeah, thank you very much, Dr. Kanupriya. Of course, I think when a new drug is there, everyone is keen to know or learn from others' experience as to if they have used this drug or not. Have you had a chance to use EV? Either in
Sir, I'm using it in third line setting in one patient. I've used it only in one patient. And that too, I'm not able to give every weekly dosing because the patient is really bothered by the pruritus. He's already a diabetic and his sugars are also haywire because of the drug. So I'm giving once in 2 weeks and that too a level 2 dosing I'm giving. I'm not giving 1.25. So the patient's symptoms, which were very bothersome of dysuria and everything has settled, but the side effects are a lot. Patient doesn't want to come back to me, come every time to OPD. He's like, I'm very troubled by the pruritus. So that becomes an issue. Otherwise, he's shown good response to the drug.
Okay. And any comment on the fact the initial trial, this 301, now we know that there are a vita criteria where we have to select or maybe filter out some patients which will not fit. Like for cisplatin ineligible, we can filter out, like you are mentioning, if the patient's HbA1c is very high, those will be ineligible.
Yes.
And any comment
Yes, sir.
on women? If I saw the forest plot, only one parameter which was showing that it was not in favor, although the numbers were relatively less. So women did not derive any benefit. In fact, it was worse with EV.
I am not sure, sir, the reason behind it. It might have to do with, we don't know the histology. It might have to do with the variant histology they had, but I'm not really sure of the reason.
Right. Okay. Thank you. Thank you very much. I think as time will pass and the cost will come down, I think we'll have more experience in using this drug. And also, once the approval comes with combination with Pembro, maybe we'll be better educated. Thank you very much. So we'll now move to the lung specific
Yes, sir.
session. Then only one session will be. Thank you very much, Dr. Kanupriya. And one session will be discussed later on. We will have a few lung specific sessions. And to begin the proceedings with lung, I invite Dr. Akansha Chabra to discuss about the Ipsos trial with the tislelizumab.
A very good evening to all. Thank you once again, Dr. Kunal and organizers, for giving me this opportunity. So, are my slides visible and are they moving?
Yes.
Okay, so I'll just start with my presentation. So, I'll be talking about shaping the first line metastatic NSCLC care with monoimmunotherapy, clinical learnings from IM Power 110 and the Ipsos study. So, these are my disclaimers, and the slides are provided to me by Roche. So, whenever we talk about a case of lung cancer, first of all, we look at the histology, whether it is non small cell or small cell. Then, if it is non small cell, especially in the metastatic setting, we look at the actionable mutations like EGFR, AL, CROSS, RET, MET, and so on, along with the PDL1 status. We also look at the overall tumor burden, whether or not there are brain metastases present, what are the comorbidities of the patient, and what is the performance status and age of the patient, and lastly, what does the patient want. So, based on all this, we decide with the treatment. So, the treatment options for patients with metastatic NSCLC without the driver alteration. For first line, we have various options like chemotherapy alone, immunotherapy alone, combination of chemo immunotherapy, or combination of anti-angiogenic drugs with all this. And in second line, whatever option we have not used in the first line, that is our go-to therapy for the second line treatment. Let's take this discussion further with the help of an example. So, this is a case of Mrs. X, a 67 years old non smoker, professor by occupation with a good performance status of ECOG 1. She has been newly diagnosed as a case of metastatic NSCLC, driver mutation negative, and PDL1 high. Let's say it is to the tune of 60%. So, in such cases, Tecentriq monotherapy is approved for use as first line in both squamous and non-squamous metastatic NSCLC with PDL1 high with no EGFR or ALK mutation based on IM power 110 results. So IM Power 110 compared the immunotherapy, that is Tecentriq alone, with the chemotherapy. So these were the results. If you look at the graph, the overall survival, the graphs, they overlap with each other. It means that overall survival was similar in these two arms. That was to the tune of 20 to 22 months. That is with a non-significant p-value. It means that we have similar overall survival with immunotherapy alone versus chemotherapy. If you look at this meta-analysis, this shows that immunotherapy alone has fewer side effects as compared to standard chemotherapy, showing us the importance of the quality of life which was maintained in the Tecentriq alone arm. So we have to balance the improved survival and thereby optimizing the quality of life. So immunotherapy alone, that is Tecentriq monotherapy, offers a chemotherapy-free option for patients with metastatic NSCLC with PDL1 high. So coming on to the study IM Power 110, which is Tecentriq monotherapy for PDL1 high first line metastatic NSCLC patients. This was a phase 3 multicenter randomized trial. The study design was very simple, took stage 4 patients, both squamous and non-squamous, chemo naive, EGFR ALK negative and PDL1 selected. It means that they divided the patients into TC1, 2 and 3, where TC3 was PDL1 of more than 50%. So divided the patient into two arms, where one arm received Tecentriq at the dose of 1200 milligram given 3 weekly till disease progression, and other arm received chemotherapy. For non-squamous, it was pemetrexed platinum followed by PEM maintenance. For squamous, it was GEM plus platinum based. Primary endpoint was overall survival and secondary endpoints were PFS, duration of response, and the overall response rates. The baseline characteristics were well matched between these two groups, and these were the results. This is the updated overall survival. If you look at the curves, the curves, they are well separated. The median overall survival was 20 months in the Tecentriq arm as compared to 14 months in the chemotherapy arm. If you look at the 1-year OS, it is 52% versus 66%, again favoring the Tecentriq arm. But the point to note is that this is in the population with TC3, that is PDL1 more than 50%. So updated exploratory overall analysis shows in PDL1 high population, there is continued OS benefit with the use of Tecentriq monotherapy. Now talking about the PFS in this population, so the median PFS was 5 months versus 8 months, again favoring the Tecentriq arm, and 1-year PFS was 19% versus 39%. Coming on to the response rate, it was 28% versus 40%, again favoring the Tecentriq arm in the TC3 population, and median duration of response was 4 times higher. So it was 8 months in chemo as compared to 38 months in the Tecentriq immunomonotherapy arm. So this Tecentriq shows the highest median duration of response as monotherapy in first-line metastatic NSCLC with PDL1 high, that is in the TC3 population. So to summarize this, Tecentriq monotherapy is approved for use as first line in both squamous and non-squamous metastatic NSCLC with PDL1 high with EGFR ALK negative based on IM power 110, and there is clinically meaningful improvement in the overall survival, PFS, overall response rate, and duration of response in TC3 population with the Tecentriq monotherapy as compared to the chemotherapy. So these were the side effects. Mainly side effects with chemotherapy, as we all know, that there was anemia, nausea and vomiting, drop in the blood counts, whereas with the atezo arm, it was more of the altered LFTs, rash, pruritus and hypothyroidism. But there were no new safety signals and Tecentriq had a favorable safety profile. So comparing, so we have a real world study which compares atezo with the PD-1 inhibitors. So this real world data from Japan shows that the rates of pneumonitis were significantly lower with Tecentriq to the tune of 5% as compared to 29% with the other PD-1 inhibitors. So now we compare the IM power 110, which is for atezo, with Keynote 024, which is for pembrolizumab in TPS more than 50%, and Keynote 042, which is for pembro in TPS more than 1%. Although the cross-trial comparison should be interpreted with a great caution, but here we'll just discuss what are the differences in these trials. So first difference was in the design. So the trial setting, the IM power 110 had patients with the liver metastasis, which were to the tune of 17%, which was not mentioned in the other two trials. Rest, we know that the atezo dose is 1200 milligram and pembro dose is 200 milligram, which is given 3 weekly. Primary endpoint being OS in the IM power and PFS and OS in the Keynote respective trials. So the median overall survival in the IM power 110 was 20 months as compared to 30 months in Keynote 024 and 20 months in the Keynote 042. But the same IO molecule shows the different OS in same subset of population. So this is something to be pondered upon, that these two trials using the same immunotherapy have different overall survivals. And if we talk about the overall response rate and grade 3 and grade 4 events, they were almost equal in all these trials. If we look at the network meta-analysis with the atezo arm, the highest overall survival is achieved to the tune of 10 months as compared to 6 to 7 months with the other PD-1 inhibitors. Coming on to Ipsos study, which is Tecentriq monotherapy for first-line metastatic NSCLC patients who are not eligible for receiving the platinum-based chemotherapy. So again, we'll discuss with an example. This is a case of 65 years old male who has a smoking history of 40 pack years, presented in the OPD with the complaints of dyspnea on exertion and fatigue. On investigation was found to have stage 4B metastatic NSCLC with bone and contralateral lung mets. PDL1 was high, that is 60%, but ECOG performance status was poor, that is 2, and having substantial comorbidities like COPD, ischemic heart disease, and was on dual antiplatelet therapy. So these patients who are ineligible for receiving the platinum based therapy, what to do in this subset of patients? So again, we have Tecentriq monotherapy, which is approved for these patients in the first line in both squamous and non-squamous metastatic NSCLC who are ineligible to receive the platinum based chemotherapy, who have no driver mutation positivity. This is based on the IPSOS study. So a brief background about the IPSOS study. We know that the first line metastatic NSCLC has shown improvement in the overall survival with the use of immunotherapy, but all these trials were done in the fit patients and with a PDL1 of more than 50%. Whereas in real world setting, around 40% of the patients have poor performance status, they have multiple comorbidities, and they have poor tolerance to platinum chemotherapy, making them ineligible for receiving the chemotherapy. So this subset population, that is vulnerable and frail patients, they represent the unmet medical need to examine the efficacy and safety of the other novel therapeutic options which are available. So IPSOS study is all about that, which took patients of treatment naive stage 3 and 4, both with squamous and non-squamous histology, with a poor performance status, and that is why they were platinum ineligible because of PS2 or 3. Or if they were having good PS, then they were aged more than 70 years with substantial comorbidities or other contraindications to platinum chemotherapy. EGFR ALK mutations were excluded. The patients were divided into two arms, where one arm received atezo, other arm received investigator choice chemotherapy, be it gemcitabine or vinorelbine. Primary endpoint being OS and secondary endpoints being PFS, the response rate, and the duration of response. The baseline characteristics were well matched between these groups, but the point to note is that majority of the patients were of the age 70 to 79 years and ECOG performance status 2. And another thing to note is that majority of the patients, 70%, 75% of the patients were having TC of less than 50%. So this is the actual subset of population which were included, which we actually see in the real world setting, with performance status 3 or with 2 with the relevant comorbidities, age more than 80 years or more than 70 years with the comorbidities. So these were the results when atezo was compared with the chemotherapy. If we look at the overall survival, the median overall survival was 10 months versus 9 months. Although numerically it was just a month higher, but if you look at the 2-year overall survival, it was double. It was 12% in the chemo arm as compared to 24% in the atezolizumab arm, providing a clinically meaningful improvement in the OS at a median follow-up of 41 months. Talking about PFS, again the PFS was numerically similar in both the arms to the tune of 4 months, but if you look at the 2-year PFS, it was 1.6% as compared to 8.9%, again favoring the atezo monotherapy arm. Coming on to the response rate, it was double. From 7%, it increased to 15% by the use of Tecentriq monotherapy, and majority of the patients, they had the stable disease and a partial response. So less than half of the patients had grade 3 or grade 4 events which were observed in the atezo arm, but there were more number of adverse events which were seen in the chemotherapy arm. So we are just talking about Tecentriq. What about other immunotherapy drugs? So we have studies with other immunotherapy drugs, but like with pembrolizumab, we have data, but that is only phase 2 trial. We do not have any phase 3 trial with this subset of population. And Nivo-IP combination and durvalumab was tried in phase 3 trial, but due to high mortality, these trials were put on halt. So IPSOS study is about the empowering the ineligible, where we cannot use platinum therapy like in poor performance status, age, poor renal function, and comorbidities. IPSOS study is there, which shows that Tecentriq monotherapy can be given in such subset of population. So to conclude, first line atezolizumab significantly improved the overall survival over single agent chemotherapy in patients with advanced NSCLC who are platinum ineligible, regardless of the histology, regardless of the PDL1 expression, whether it was less than 50% or more than 50%, and regardless of the ECOG performance status. Tecentriq monotherapy showed 2-year OS rate of 24%, which was double as compared to chemotherapy, with a durable response, and the health related quality of life was maintained with no unexpected safety signals. So this is the first randomized phase 3 study which shows that first line treatment with atezo improves the overall survival in this poor prognosis NSCLC population with no EGFR and ALK mutation, regardless of the histology, regardless of the PDL1 status or ECOG performance status, with no new safety signals while maintaining the quality of life. So that's all from my side. I thank all for patient hearing. Thank you, Dr. Kunal, once again, and thank you, Rosh, for providing the slides.
Thank you, Dr. Akansha. So, one very quick question. Would you do PDL1 testing once you have done EGFR ALK? Let's say it is, although we can get the PDL1 testing earlier. So, would you do PDL1 testing for a patient? Let's say, I think the good thing about this study is that it mimics the real world setting where we get patients who are poor performance status and all the comorbidities. So, the question is about PDL1 testing.
So definitely I would go for the PDL1 testing along with all the mutations, because first that the if there is EGFR and ALK, all the driver mutations are negative, then we'll look at the PDL1 to look whether we can give immunotherapy alone. So IPSOS study is about where the patients are ineligible for the platinum therapy.
Yes, we are talking about that situation.
Yet I would go with the PDL1 testing as well, because prognostically also and the responses also will tell us with the PDL1 testing only.
All right. Okay. Thank you. Thank you very much. So next is about EGFR mutations and optimizing the first line strategy. And we have Dr. Sandeep Cooker to present about osimertinib.
Thank you, Dr. Kunal. Thank you so much. Good evening. Good evening, everyone. So today I have been given the responsibility to talk something on the role of chemo and TKIs in the first line EGFR metastatic non-small cell lung cancers. So I think we all agree that the first line treatment has taken a new landscape since the advent of osimertinib. And secondly, now the focus has been to take off the resistant mechanisms that are there with the use of either a chemo and TKI based approach or amivantamab and lazertinib based approach using the bispecifics. So the confusion will remain, but let us see what the future has in for us and what we are here to talk about. So there is around 35 to 40% of the patients are EGFR mutated NSCLC. And in India also, the data is to the tune of around 33 to 39%. EGFR mutations are located in tyrosine kinase domain, leading to an increased kinase activity of EGFR, leading to increased cell proliferation. And we all know that the common mutations are DEL19 and exon L858R. So we started from IPAS, where the median progression-free survival was less than a year to the tune of around 9 months, 9.5 months. And now we are looking at a progression-free survival of approximately 2 years, which I would say the jump has been enormous, almost more than 2.5 times. So now the strategy has been to overcome the resistant mechanisms, and how it has been done. It is by combining the cytotoxic chemotherapy, inducing the apoptosis and delaying the resistance by suppressing the AKT and extracellular regulated kinase phosphorylation. Oral TKIs, it enhances the pemetrexed efficacy to an extent by decreasing the thymidylate synthetase level. So there has been a rational combination of using a cytotoxic chemotherapy along with a TKI. In the past, also several studies have been done, and the response rates have been better to the tune of approximately 15 to 20% in different studies, with the variable combinations of erlotinib, gefitinib, icotinib, and now we have the FLORA2 study where we have combined the osimertinib with a pemetrexed carboplatin based regime. So this was दवाओं के तालमेल, synergy और उनके संयुक्त प्रभाव को समझने के लिए महत्वपूर्ण है. Sorry for that. विभिन्न अर्थव्यवस्था. Sorry for that. So FLORA 2 was a trial design where untreated locally advanced metastatic EGFR NSCLC, the key inclusion criteria were patients were metastatic, they had either exon 19 or L858R by a local and a central test. No prior systemic therapy, patients with the stable CNS metastasis were allowed. The arms were stratified using the RACE, EGFR, local central test, and the performance scale. Randomization was done between osimertinib with chemotherapy versus osimertinib alone. 4 cycles of chemotherapy were allowed, and osimertinib was continued as a maintenance therapy thereafter, along with continuation of pemetrexed. The primary endpoint was a progression-free survival, and the secondary endpoint was a overall survival, overall response rate, duration of response, quality of life, safety analysis. So we'll see something about it. So baseline characteristics, the important highlight was that 40% of the patients had stable brain metastasis and 50% of the patients had extrathoracic metastasis. So the progression-free survival was better if you look at the osimertinib with chemotherapy arm compared to osimertinib monotherapy to the tune of around 9 months with a hazard ratio of 0.62. The curves are very well separated. And via a blinded independent review committee, the results were even better to the tune of around 10 months with a hazard ratio of 0.62. Looking at the looking at the progression-free survival in terms of the subgroup analysis, so all the subgroups, the PFS benefit was consistent. All the subgroups were deriving the same quantum of benefit, but the important highlight was in patients who had CNS Mets at baseline, the hazard ratio was 0.47. Again, highlighting the importance of adding osimertinib, particularly which penetrates the blood-brain barrier. Now, looking at the CNS Mets subset in particular, if you look at both the curves, CNS Mets without brain Mets and with brain Mets, hazard ratio in terms of with brain metastasis was around 0.47, and without brain metastasis it was 0.75. So patients with CNS Mets had a median progression-free survival of around 25 months, almost replicating the same that was in tune with the overall population. So if you look at the subgroup analysis in terms of mutation analysis, exon 19 and L858R, the curves are very well separated. Hazard ratio is to the tune of around 0.6. Median progression-free survival, very, very similar, approximately 27.9 months. So now looking at the overall survival was also better. If you look at the 3-year OS, it is approximately 64% versus 50%. The median follow-up for OS was approximately 2.5 years. So looking at the numerically, if you look at the median overall survival, it was approximately 48 months, and 4-year overall survival was approximately 50%. So around 50% of the patients were alive at the end of 4 years if they were continued on osimertinib with pemetrexed. Overall survival, if you look at in terms of CNS metastasis, again highlighting the same point, the hazard ratio is improved, and it is to the tune of around 0.7. The OS benefit was seen very, very consistently in all the pre-defined subgroups, whether it is smoking history, whether it is the differentiating factor of exon 19 L858R, or the presence of brain metastasis. Median duration of exposure of osimertinib exposure in OSI plus chemo arm was approximately 9 months longer compared to the osimertinib monotherapy arm, and median pemetrexed exposure is much shorter than osimertinib exposure, suggesting a long chemo-free interval to progression. Now, looking at the acquired resistance, I think if you look at all the 3 studies, whether it is FLORA osimertinib monotherapy, FLORA 2 osimertinib monotherapy, and FLORA 2 osimertinib with platinum pemetrexed subset, the resistance mechanisms are almost very, very similar. But if you look at numerically, I think majority of the times we look at MET amplification. It was approximately 15-16% in the original FLORA study, and it was 9% in the FLORA 2 study. So if you look at all the mutations numerically, numerically the numbers are a bit different, but I think not very significantly different. It is almost to the tune of say 1 or 2%, not more than that. So they concluded that the treatment with the combination did not affect the resistance mechanisms, and it remained very, very similar across the FLORA and FLORA 2 trial. Safety concerns, we all know that majority of the times it is the hematological toxicity and the diarrhea that takes over. Anemia was seen, diarrhea was predominantly seen, and grade 3 side effects, more than grade 3 side effects were seen in approximately 70% of the populations. And if you look at the discontinuation rates of osimertinib, it was 12%. Discontinuation rate of pemetrexed, it was to the tune of 50%, which is again very high. So looking at all the three studies, NEJ009, where gefitinib with chemotherapy was given, TMH study of gefitinib with chemotherapy, and the FLORA2 study. So the grade 3 side effects, predominantly hematological, are seen in approximately 70% of the patients, where the number is high. And apart from hematological toxicities, skin toxicities, again, very, very similar in tune with what we see the hematological side effects to the tune of around 50 to 60%. So all the trials, they reported high adverse effects attributable to chemotherapy, and it was seen very, very consistently and similarly in all the studies. So if you look at the combination, the comparison between the monotherapy and the combination studies, yes, to an extent, it will lead to a better progression-free survival because it has an improved, enhanced efficacy. And probably the hypothesis is that they stated that it will lead to improved efficacy of the chemotherapy regime and it will take care of the resistance mechanism, is what the hypothesis was made, and it was proven also in terms of progression-free survival benefit to the tune of approximately 2 years to 2.5 years by the BICR. And overall survival, again, 48 months approximately. We are reaching a tune of around approximately 4 years now. CNS Mets, the very difficult population to treat, where osimertinib is one agent which is proven to have efficacy, and the difference is approximately a year, 15 months versus 25 months. I agree, the side effect profile is, it has to be managed, and you have to be very cautious about giving the maintenance therapy in terms of osimertinib with pemetrexed in particular, where you tend to continue the dose till progression of the disease. So at times it becomes difficult, but I think either you have to change the dose or the schedule depending on your patient's tolerance profile. In terms of now, the concept has been there, the selecting the agent or the selecting the therapy in terms of either looking at the mutations. So again, the benefit in terms of osimertinib and chemotherapy was very, very consistently seen with Osi and combination-based chemotherapy arm, even if you compare it with amivantamab and lazertinib. So the new treatment algorithm has been either osimertinib monotherapy or a Osi with chemotherapy-based approach or amivantamab and lazertinib-based approach. Second line, we all know that either it is amivantamab, lazertinib, or majority of the times we end up giving chemotherapy. And third line, again, if you have not used the regime earlier, you can switch over to those regimes in the third line. So in summary, osimertinib in combination with platinum-based, pemetrexed-based combination therapy offers a significantly and clinically meaningful improvement in progression-free survival to the tune of approximately 24 months, 25 months, and a hazard ratio of 0.62 with a better CNS penetration rate, PSFS of around 25 months in those who had metastatic lesions at baseline. It also not only improves the progression-free survival, but also leads to an overall survival of approximately 48 months, which is again the longest in any global phase 3 study showing a OS benefit in this population. And the benefit was observed consistently in the predefined subgroups. Only thing is you need to be cautious about the side effect because if you look at the discontinuation rates of pemetrexed, it is approximately 50%, and osimertinib it is around 15%. So only thing you need to remember is how to handle the toxicity in such patients. So with this, I end my talk, and thank you for giving me the opportunity, Dr. Kunal. The final statement, I would say that there has been a debate about whether to use the FLORA2 or the Mariposa based approach. But again, the things are not very clear because both the trials, they do offer numerically, if you see, FLORA2 offers a better PFS, I think to the tune of around approximately 2 months, and the overall survival not reached versus 4 years of therapy. But if you look at the uh, certain combinations, certain subgroups, so whatever I went through, number one, any patient who wants a chemotherapy free therapy could be offered. Number one, number two is could be a TP53 based mutation where again some of the data is tilted towards using a amivantamab and lazertinib based approach. Third is if you are too much concerned about marrow toxicity in particular, I think one should avoid using the FLORA2 based approach. FLORA2 can be used for a young and fit patients with a high tumor burden. It will be the way to go with the patient who has a symptomatic disease where you want an early response, and patients who are willing to accept that toxicity. Again, it will also, the onus will lie on the clinician how to handle the toxicity and how to modify the schedule of pemetrexed depending on the patient's profile. So thank you.
Thank you. Thank you very much, Dr. Sandeep. And despite your, we can understand your sore throat, your voice was quite crystal clear and energetic. So, just one quick comment on why do you think the combination did better in CN? Because the drug which is going to work in the CNS disease is osimertinib. So, what was there any reason given why the chemo plus osimertinib did better than osimertinib alone?
So no particular reason. You are right in the way I think osimertinib is one agent which penetrates the blood-brain barrier. Only what I could think of is you are reducing the tumor burden by giving 4 cycles of chemotherapy earlier and then using osimertinib and pemetrexed. So maybe reduced burden of disease might be one of the reason. I don't know about that, but definitely the agent which penetrates is osimertinib.
Yeah, I'm just also trying to think about the patients where I had used osimertinib, and I can't think that those patients were fit enough or they had that kind of performance status where I could have combined with the chemotherapy. And I have not had any experience with the amivantamab and lazertinib. Is it available, lazertinib, right now?
So it is available, but I think I don't have a personal experience regarding that. It is available.
So
Right.
good
Thank
evening,
you.
sir.
Sir, I have a one question.
Just one thing, like what Sandeep was saying that but we are discussing that increased effect. Maybe this chemotherapy has caused some sort of a enzyme induction, or which has caused an increased level of this osimertinib in the body blood, which has caused a much more better effect. This could be a possibly theoretical reason, if you ask me. Otherwise, there is no other way why this chemotherapy and osimertinib gave a better outcome in the patient with the CNS metastasis.
Sir, can I ask one question?
Please go ahead.
Sir, so it our generally in lung cancer EGFR mutation, most of the patients are not feasible for osimertinib Tagrisso for original. So we in our institute generally we are giving PEM carbo with gefitinib. So is there any experience regarding that generic osimertinib which are available? Can we use that osimertinib single or with chemo? Because most of the patients are not affordable for that original osimertinib, sir.
So I think I have not used the Bangladeshi version of osimertinib in my practice. I have used the TMH based approach, gefitinib with chemotherapy, and believe me, it offers remarkable results. I think we have seen in high burden and symptomatic patients where we have used gefitinib with chemotherapy. Again, the combination is really very effective if your patients cannot afford osimertinib.
But that
Only thing is we face challenge in continuing while maintenance. Once you have given 4 cycles of chemotherapy or 6 cycles, usually I tend to give 4 cycles and then continue them on maintenance therapy. But again, using pimetrixate along with osimertinib for a very long time would be one challenge to ponder upon.
Yeah, we cannot. I think the correct answer for that is there is, to be honest, there is no generic version. That is kind of a non-existent kind of thing. And now with the current geopolitical crisis, I think it is better that we do not discuss that issue also. One thing about the Jeftinib trial was not with pemetrexed, if I am correct. It was with paclitaxel and carboplatin.
Paclitaxel.
No, sir, it was
Hey, it
Pemcarbo
was
with
pemetrexate, sir. It was pemetrexate.
Pemcarbo,
Pemcarbo Zephyr, sir.
Pemcarbojef.
It's
Yes,
Pem
sir.
carbo.
The TMH study was based on pemetrexate, carbo, and Jif.
Hmm. All right. Okay, so we'll move to the next talk on ALK mutated or ALK rearranged lung cancers. And for that, I invite Dr. Prabhat Ganju to give the talk, please. Thank you.
Hello, everybody. Good evening. Thank you, Dr. Kunal Jain, for inviting me. Should I be sharing my slides?
It's up to you if you have the slides. I think
Yeah, I'll share.
it's better to.
Okay, so I'll be moving on from EGFR mutated lung cancers to the next most common, that is ALK mutated. And so I'll talk about the path that we've taken from the initial discovering of the ALK mutation to the current standard of practice and how it has changed over the years. So as we know that lung cancers, non-small cell with altered actionable mutations comprises around 30 to 40% of all non-small cell lung cancer cases that we see. And this population in India is in the Asian population shows a higher proportion of mutated driver mutation positive lung NSCLC, which is around 45-46% versus around 6 which is much lower in the Western population. And the kind of mutations that we also see are different, where KRAS mutations are less common, and EGFR is exon 19 and L858 are the more common mutations. And we know about the different kind of targeted therapies that are approved for the different driver mutations that we have. And now we have subsequent targeted therapies. We have generations on generations of targeted therapies which have shown to be superior to their previous generations. And so if you look at ALK mutation here, so first, about the detection of ALK mutation, we have different tests. We have IHC, FISH, RT-PCR, and NGS. Out of these, I think IHC is a good test. It's highly sensitive, specific, and is very easily available. But the issues being sometimes it can show false negatives and false positives, and you do not get the detail of what is the fusion partner or the breakpoint. Similarly, with fish, obviously with a longer turnaround time and special kind of training that is required and interpreter bias, this also does not give you the detail of the fusion partner or the breakpoint. And so it's not the ideal test here. RT-PCR again will only give you known fusion and breakpoints, and you will not know, you cannot detect unknown or novel fusions, and high rate of it leads to high rate of false negatives. The NGS here is definitely preferred due to its practicability and higher accuracy, and versus sequential single gene testing, which takes a very very long time. So multimodal testing may increase the accuracy of ALK fusion identification. So NGS as of now seems to be the preferred way to go. So if we look at the ALK inhibitor development timelines, we started with the discovery of the EML4 ALK translocation in 2007. We had the first generation crizotinib, and then ceritinib, alectinib, brigatinib in the second generation over the last 15 years. And now with the advent of lorlatinib, which is the third generation, we slowly have data that has come in which has shown even better response rates. And so as we go over the generations, there is increasing activity against ALK. There's a broader coverage of ALK resistant mutations, and there's improved penetration into the CNS, which these three seem to be the things that are being targeted now to improve survival. So the unmet need in ALK positive NSCLC is that these patients are generally young non-smokers or light smokers. 20 to 40% have brain metastasis at baseline, which leads to poorer prognosis. And for a durable control of brain metastasis in these patients and to prevent further uh, development of brain metastasis in those without them, this is the reason why we need the third generation TKIs and the drugs in the future to have these kind of responses for CNS and to cover the various resistance mutations that are found in ALK. So 1 in 3 patients do not receive second line treatment despite the development of second generation ALK targeting therapy. And as I mentioned, 25% will never get a second line therapy. And this is why the first line therapy becomes very important. And so many of these patients do not receive any subsequent treatment, whether it's chemotherapy or any other targeted therapy. And over the course, any kind of chemotherapy is received in about 67% of patients. So this is why the first line treatment becomes very important, as a lot of them do not receive any subsequent therapy. So in the World Congress of Lung Cancer in 2024, a paper was presented about the use of second generation ALK TKIs in those with brain metastasis and those without brain metastasis, and how almost they saw that 20% of patients go on to develop brain metastasis despite receiving CNS penetrant second generation TKIs. And so the need to develop further third generation TKIs was there. So how do we decide first line therapy for ALK mutated NSCLC? There are many factors. We have to look at the response rates, progression free survival, overall survival. How is the efficacy in the CNS? How is the overall survival shown in the trials, and what do we have for second line after that? How is the toxicity profile of the drug that we are choosing? So all these factors we have to keep in mind. And so the Crown study was developed, where this was a phase 3 study where they tested lorlatinib in advanced ALK mutated NSCLC and included patients who had asymptomatic treated or untreated CNS metastasis. So they were randomized to lorlatinib versus crizotinib, which was the standard of care at that point of time. And the primary endpoint was PFS, and secondary endpoints were OS, PFS by investigator, and safety. So at the planned interim analysis at 18.3 months of median follow-up, the median PFS was not reached for lorlatinib and was 9.3 months with crizotinib with a hazard ratio of 0.28. In the subsequent 3-year follow-up, the median PFS was still not reached with lorlatinib and was 9.3 months with crizotinib, with again very impressive hazard ratio of 0.27. So at that point of time, until 2024, the first line treatment options for ALK positive NSCLC were either lorlatinib, which gave a median PFS of around 36.7 months, alectinib, which gave a median PFS of 34.8 months, and brigatinib, which was around 30.8 months. And so then when we got the 5-year analysis, a lot of things changed. At 60 months of median follow-up, the median PFS by investigator was still not reached with lorlatinib. So this was the longest reported PFS in advanced NSCLC till date. So 60 at 60, which means 60% of the patients were alive at 60 months in the lorlatinib arm. So this gave a hazard ratio of 0.19. The overall response rate was 81% versus 63%, and with a CR rate of 15%. So this was not just for all patients. If we look at the stratification based on with brain metastasis or without brain metastasis, these PFS benefit is consistent. So it is irrespective of whether you have a brain metastasis at baseline or, and the PFS benefit was 53%. So if we look at the Asian subgroup data, again, the median PFS was not reached with lorlatinib and was 9.2 months with crizotinib. And the probability of being progression-free at 5 years with lorlatinib is 63%, which is again very impressive. The PFS benefit, as expected, was seen across all patient subgroups. With if you have brain metastasis, the survival benefit is even more with lorlatinib. And if we apply the rule of two, which is that the first generation TKIs, crizotinib, and the second generation ceritinib, were had a two times better median PFS than chemotherapy. The alectinib and brigatinib had a twice better median PFS than the first line crizotinib and ceritinib. And lorlatinib now has shown to be again twice the amount of median PFS with around more than 60 months has now reached. So if we think that, okay, we don't have the OS data and we're just going by the PFS, the 4-year OS for the Alex trial, alectinib was 65%, and for brigatinib was 66%. The 5-year OS with brigatinib is 62.5%. In comparison, if we look at lorlatinib, the 5-year OS was around 76% in treatment naive ALK positive NSCLC. And the median OS has never reached, as of now, median follow-up of around 72.7 months. Median OS was never reached. And so OS follow-up is currently going on, and we will know the median OS in due time. So as of now, the 5-year PFS of 60% is itself very impressive. So considering that more than half of the lorlatinib patients have to die to trigger the release of OS data, and 60% of the patients are still on the drug at 5 years. So at present rate, the median PFS may reach 9 years. And so this begs the question that do we really want to wait for that long to extend the benefit to patients? And so if we look at the time to intracranial progression, that again shows a marked difference between lorlatinib and crizotinib. There's a hazard ratio of 0.06, and there were no intracranial progression events after 3 years, which was also very impressive. So time to IC progression was longer with lorlatinib, whether there were brain metastasis at baseline or without a brain metastasis as baseline. And 4 of the 114 CNS failures happened in the first 16 months. So in summary of the overall and intracranial response, complete intracranial response with lorlatinib was seen in 58% patients, whereas that was 38% in the Alex trial. So subgroup analysis, there was even survival benefit, which was seen in patients with poor prognostic biomarkers. So the PFS in that V3AB subset, which is supposed to be a poor prognostic marker subset, was 17.7 months in Alex, and in Alta it was 16 months, whereas the median PFS with lorlatinib in the
Sorry to interrupt, sir. Kindly
is
conclude.
around 60 months again. So in P53 again, this benefit was seen in the lorlatinib arm, 51.6 median PFS. So now coming to safety, and what is interesting to see is that dose reduction was seen in around only 23% patients, but temporary discontinuation will be seen in more than 60% of the patients. Permanent discontinuation, on the other hand, is only around 11%. And treatment-related adverse events that led to permanent discontinuation in around 5% patients, and those occurred mainly during the first 26 months of treatment. So we know that adverse events leading to permanent discontinuation were around 11% with Crown trial, which is also comparable to the previous generation TKIs. All causalities, adverse events which occurred more than 10%. So the most common grade 3 and 4 adverse events with lorlatinib were hypertriglyceridemia around 25%, increased weight gain, and hypercholesterolemia along with hypertension. Also, pedal edema is another troublesome side effect that we do see. And if we see the median time to onset and the duration of these adverse reactions with lorlatinib, hyperlipidemia occurs the first, which is around in the first month itself. Mood effects and psychotic effects start developing in the second month. Peripheral neuropathy is much later, and cognitive effects come much later in the somewhere around 6 months after starting treatment. So, if you look at hyperlipidemia, it's reported around 72% of the patients do experience hypercholesterolemia and 66% with hypertriglyceridemia. But only 1% of patients who experienced hyperlipidemia had to discontinue treatment. CNS adverse events were seen completely in around 42% of patients, but only 2% of the patients had to discontinue treatment. Edema and weight gain are also seen around 50 and 44% of the patients. So hyperlipidemia is of any grade is quite common. Hypertriglyceridemia and hypercholesterolemia of grade 1 and 2 were most commonly seen, and grade 3 and 4 were much less common. And conservative management or no intervention was the way to go in most of these patients, and these resolved also in a lot of these patients. So what can be done is you can start lipid lowering agents at baseline if there is some dyslipidemia at baseline. So pitavastatin, pravastatin, and rosuvastatin can be considered as their low interaction with the CYP3A4 enzymes. So cognitive defects, mood defects, and the CNS adverse events, mostly grade 1 and 2, and those are in line with prior analysis also. And only 3 patients in the lorlatinib arm had to permanently discontinue due to CNS adverse events. And most of these CNS adverse events did not require any medical intervention and can be managed with conservative management or no medical intervention. So about monitoring toxicities, as I mentioned that we need to measure lipid levels at the beginning, and if deranged, then you need to start one of these statins. Also, if the cholesterol levels or triglycerides are elevated, we have to start lipid lowering therapy if not initiated earlier, or change dose. And you also might want to stop the drug and reduce the dose if this hyperlipidemia is in a life-threatening level or is not resolving with the statins. And the other toxicities, again, we have to like weight gain, edema, and neuropathy. If it is mild to moderately bothersome, then you need to stop the drug and consider for dose reduction if it is not resolving. Whereas if it is severely bothersome, you need to reduce the dose. So dose reduction did not impact the efficacy of lorlatinib in those patients who had a dose reduction in the first 16 weeks. And the median PFS and time to intracranial progression were comparable in both these arms. Also, in the ASCO 2025, we had a real-world analysis where data was presented from 9 centers across India. And this was an ambispective study where they took around 36% patients in the retrospective and 15 prospective, and 94% had baseline metastatic disease. And brain mets were seen also in around 49% of patients. And here, an objective response rate of 74.4% was seen with an IC response overall response rate of 70%, which was comparable to what is seen in the Crown trial. And also toxicities, around 30% of the patients had hypertriglyceridemia, and 27% had hypercholesterolemia, which is much lower than what was seen in the Crown data. And so this study kind of showed us that even in the Indian population, that effectiveness and tolerability was consistent with the data from Crown. And so, based on all this, lorlatinib is a clear frontline choice for ALK mutated NSCLC. I don't think there is any debate about that. The only problem being that therapy after lorlatinib is limited. And so, we obviously, in that population who do not respond to lorlatinib and who progress in the initial few months, as we have seen, those might be a population that is not going to do well, even though they are ALK mutated. So with that, that's the end of this presentation. Thank you very much.
Thank you, Dr. Prabhat. I think that is one area where I think things are more sorted for us because everywhere else there is so much of confusion as to which therapy to use. There we have a clear winner.
Yeah, I think so.
Not soon we will get something which can overcome a PFS which has not been reached, 5-year PFS. So
Yeah.
I think that is one. It's a great data, and the only problem that we have is with the cost. So, do you have any patient population where you would not use lorlatinib?
Obviously, considering the side effect profile, if somebody with uncontrolled hypercholesterolemia, hypertriglyceridemia, because we see it very commonly with lorlatinib, I think probably that population, we would want to reserve it at a later time, maybe start on a second generation TKI, control that the triglyceridemia and the cholesterolemia, and then maybe in second line you can think of it. But otherwise, there is hardly any sort of patient, any subset of patient where we would not prescribe lorlatinib. Yeah.
Yeah, I think, yeah, correct. Along with that, maybe somebody with a neuropsychiatric illness, I think that
Yeah.
is one area where you would be skeptical of using this drug because of more lipidemias you can
Yeah,
still
can
manage
manage.
somehow, but I think that setting will be, but I agree. I think if somebody has that kind of a problem, although it did not show any significant worsening in cardiovascular
Yeah,
events.
that's true.
Right. Thank you. Thank you very much. So we move to the next session on immunotherapy in lung cancer, use of tislelizumab. So we have Dr. Jagdeep again ready to go. So over to you, Dr.
Thank you, sir. Thank you for so
I didn't
kind
use
words.
the director mic.
That's why I said thank you so much.
Okay.
Thank you. Good evening, everyone. And thanks, Dr. Kunal. So I'll be sharing my screen. So I think now is it in presentation mode?
Yes, sir. Yes,
Yes.
sir. It's there. Now we can start, please. Yeah.
Thank you so much. So my today's talk is immuno-oncology in motion. So we have this new drug, another anti-PD-1, that is tislelizumab, and it's a tislelizumab's promise for a lung cancer carcinoma. So just an overview of this drug. So it's a Ig4 monoclonal antibody with a high affinity and binding specificity for this PD-1, and it is having it is differentiated by other anti-PD-1s with a different binding epitopes, and the recommended dose is 200 milligram administered every intravenously 3 weekly. So this is some global development plans, and there are some approximately more than 20 potential registration enabling clinical trials in 35 countries. So there is clinical programs have been closed for approximately close to 13,000 plus patients with more than 7,50,000 patients treated commercially. So this is another drug which has given a good result with affordability and of course patient. We have a large phase 3 RCTs with this drug also, which have clearly demonstrated its efficacy over the conventional treatment. So these are the broad spectrum indications approved. And of course, in our country, we have the approved indication for the first line squamous cell and non-squamous cell lung cancer, and the second line non-small cell lung cancer, and again, second line as a esophageal squamous cell cancer. So these are the major clinical trials. So you can see, so phase 3 trials are marked with a red marker. So a lot of phase 3 clinical trials which have been approved, and the phase 2 trials are also there in different diseases. So again, similarly, continuing the same, the different phase 3 trials. So majority of the drugs like even SCC, urothelial carcinoma, and this nasopharyngeal carcinoma. So in a lot of disease that has been approved, and some trials are going on. Shortly, we'll be having the results of these trials also. So now coming to the tislelizumab profile. So basically, it has a distinctive binding orientation to the PD-1. So and because of this a unique binding orientation, it differs from its binding kinetics as compared with the pembrolizumab and nivolumab. And you can see that because of this a different binding orientation, so the blockade with the PD-1 along by this anti-PD-1 is more than 99% as compared to 80 to 80% in with the pembrolizumab or nivolumab. So these spatial binding orientation has made this tislelizumab more, you can say a binding capacity has increased with the PD-1 receptors. So this is coming to the mode of action. Not going into detail. We all know that how this thing sets into motion, and how all these TCRs and all these drugs play action and bring about the effect. So coming to this tislelizumab, so in preclinical models, this had demonstrated a high target affinity and slow dissociation from the PD. And in preclinical models, tislelizumab has shown a lower half maximal inhibitor concentration values, thus having a stronger anti-tumor activity. So now coming to the main trials, that's a clinical evidence which supports that tislelizumab in the different settings. So first coming to non-small cell lung cancer. So coming to this rational 307 trial in which tislelizumab plus chemotherapy versus chemotherapy alone for advanced squamous non-small cell lung cancer in the first line setting. So you can see in this, this is a phase 3 trial, and the study design has been mentioned. And there were 3 arms. In the arm A, this tislelizumab plus paclitaxel 175, and arm B was nab-paclitaxel 100 milligram every weekly for 3 weeks. And arm C was, of course, the conventional chemotherapy. And after completion of this 6 cycles, maintenance was given tislelizumab till progression. And the stratification was based on the stage and the PD-L1 testing. And the primary endpoint was the PFS, and the secondary endpoint was the overall response rate, duration of response, oral safety, and overall survival. So the most important thing is that tislelizumab was initially tested in the phase 2 trial as a monotherapy in the same dose, that is 200 milligram, irrespective of the PD-L1 testing, and it has shown good result even in those patient who had a PD-L1 close to or less than even 1%. So coming to the PFS, so independent review assessed PFS for the arm A and C. So you can see the patient who received tislelizumab with paclitaxel 175 milligram. So compared with the conventional chemotherapy, you can see the median PFS was 7.7 months in the arm A versus 5.5 months with the arm C. So approximately with this reduction in the risk of death or progression was 55% with the patient who received this combination. So when we are comparing the arm B with C, where we are giving the nab-paclitaxel in the weekly for 3 weeks, so you again can see that the median PFS is again 9.6 months versus 5.5 months with the patient who received the conventional chemotherapy. So significant reduction in the risk of death or prognosis was 57%. So PFS was significantly improved with the tislelizumab plus chemotherapy compared with the chemotherapy alone at a median follow-up of 16.7 months. So coming to the subgroup analysis, if you see the tislelizumab, so arm A versus arm C, so majority of the things you can see down the table, all they're favoring irrespective of the age, gender, performance status, smoking status, disease status, either stage 3B or 4, and even with respect to the PD-L1 expression. So the combination, that is the tislelizumab plus the chemotherapy, that favors as compared to the chemotherapy. So similarly, pattern was seen again in the patient who received arm B drug versus arm C. So PFS was significantly improved irrespective of the PD-L1 expression or disease status. So this is one of the most important thing. If you have a scanty tissue, or sometimes we are not able to do a PD-L1 testing due to some of the logistics, not financial constraint. So this drug, I think this is another good drug which can be used in the first line setting, the patient with a squamous cell non-small cell lung cancer, and it has been shown given a good response to the patient who received this combo along with the chemotherapy. So coming to the best overall response rate as assessed by the committee, you can see that it is with the tislelizumab, and that is arm A is close to 72% and arm B is close to 74.8%, and with arm C it is nearing to 50%. So there is significant improvement in the overall response rate in the patient who received this chemotherapy plus tislelizumab. Coming to the disease duration of response, it is 8.2 months in the arm A versus 8.6 months in the arm B versus 4.2 months in the arm C. So again, coming to the overall survivals, you can see with the intention to treat analysis patients. So arm A has a 26.1 months versus 23.3 months with the arm B versus 19.4 months with the arm C. So it has shown that patient who received this combination, they had a better overall response rate in those. And again, there was a improvement in the overall survival in the patient who received this combination of tislelizumab plus chemotherapy. So coming to the next trial, that is a rational for again, which was tislelizumab plus chemotherapy versus chemotherapy alone, again in the non-squamous non-small cell lung cancer, again in the first line setting. So similarly, design of the trial, and again comparison with the chemo plus tislelizumab versus chemotherapy, and the continuation of tislelizumab or pemetrexed versus pemetrexed alone continuation. So the similar stratification factors and similar endpoints for the PFS and the secondary with the overall response rate, OS, and duration response, safety profile. So you can see the patient who had received this tislelizumab along with the chemotherapy arm, the median PFS was 9.8 months in the arm A versus arm B, which was 7.6 months, with a hazard ratio of 0.63. So there was a significant reduction by 37% of the risk of death or progression. So the patient who received this tislelizumab plus chemotherapy, PFS was significantly longer as compared to the chemotherapy alone at a median fall of 16.1 months. So coming to the efficacy, you can see the overall response rate again was 57.4% with the tislelizumab plus chemotherapy combination as compared to 36% with the chemotherapy alone. So responses rates were higher and response duration was again longer with the combination therapy versus chemotherapy alone. So whatever the data we got reflected in the previous anti-PD-1, that is a pembrolizumab, similarly same settings. So the non-small cell lung cancer, either squamous or non-squamous, we can see there is a significant improvement in the survival with the combination of this newer anti-PD-1 drug, that is a tislelizumab. So coming to a next trial, that is a rational 303. This is for the patient who received this drug as a second or third line patient who have already advanced or metastatic NCLCL, and it was compared with the docetaxel in the comparative arm. So patient, they were given this treatment until the unacceptable toxicity or disease progression. And again, stratification was based on the squamous versus non-squamous, whether it was a second or third line, and again based on the PD-L1 status that is less than 25 or more than 25%. So primary endpoint was in this, so the overall survival in the intention to treat population analysis, and in the PDL1 more than 25%. And the key secondary endpoint was the overall response rate, PFS, health related quality life of index, quality of life, safety, and duration of response. So you can see that efficacy, the overall survival rate patient who received this tislelizumab in the subsequent therapy is approximately 16.9 months versus 11.9 months with the docetaxel. Again, it was statistically significant. And with respect to the overall survival, when we are comparing a PDL1 more than 25%, the median OS was 19.3 months versus 11.5 months. So there was a significant prolongation in the overall survival in the patients in the intention to treat analysis patients, as well as a patient who expressed PDL1 more than 25% as comparison to the docetaxel in these group. So 5-year data, you can again see the median OS was 16.9 months versus 11.9 months in the intention to treat analysis patient population. And with respect to the patient who have PD-L1 expression more than 25%, you can see the median OS was 19.3 months versus 11.5 months. So even that the 5 years that response was maintained, and you can see the patient the significantly prolonged OS in these patient population. So coming to the subgroup, you can see the patient who received this drug in the second or third line. So with respect to the PDL1 expression, so if the PDL expression it is less than 25% or more than 25%, or various comparison that is a 1% or more than. So similarly, different subsets they have seen the patient who have received this drug, so they have benefit even with the less than 25% of PDL, but it is more pronounced with the PDL expression more than 25%. So coming, sure. So coming to the efficacy, you can see again PFS overall response rate duration of response was better with the combination of the tislelizumab, with tislelizumab as compared to the docetaxel in second or third line. So again, this is one of the important, the biomarker analysis. So the patient who have this notch 1 to 4 mutation, they usually have a poor prognosis. So tislelizumab in those subset of patients, they tend to do better as compared to the chemotherapy. So both OS and PFS was prolonged in those patients who are having this notch 1 or 1 to 4 mutations. So this is another one good literature available which show the network meta-analysis which compared this tislelizumab with other in an indirect comparison to the other anti-PD-1 in the or subsequent lines patient who are having advanced or metastatic NCLC. So you can see with regards to PFS in the first line squamous non-small cell lung cancer, this combination of tislelizumab plus chemotherapy was statistically significantly more favorable than nivo monotherapy, atezolizumab plus chemotherapy, nivolumab plus chemotherapy, and nivo-EP combination therapies. So coming to non-squamous first line.
Jagdeep sir, sorry to interrupt, but if you can conclude in next 1 minute, please.
Okay, sure. So again, this PFS again, it is again in non-squamous is also improved. So now to conclusion, this tislelizumab is a highly active and efficacious PD-1 inhibitor, and monotherapy in second line non-small lung cancer and chemotherapy plus tislelizumab in first line squamous non-small lung cancer, and first line in non-squamous with the PDL more than 50% was found to be comparable to or more favorable than other anti-PD-1 therapies in the overall survival, PFS, and treatment-related adverse events. So these findings provided clinical evidence for benefit of tislelizumab and representing an additional immunotherapy option for patients with advanced or metastatic first line and second line. So not going to details. So with respect to the adverse events, so it is almost same what we have experienced with the other, that's with the nivo and pembrolizumab. So no new safety concern was there for their drug. That is that for the tislelizumab. So thank you for your patience listening.
Thank you very much, Dr. Jagdeep. These new drugs are coming up and catching up with the old war horses, and we are using them, I think, more often. So thank you very much for presenting the data about tislelizumab. We now move to the panel discussion on endometrial cancer, and that for that I'll request Dr. Sachin Gupta, who's the senior consultant medical oncologist at Max Mohali, to please take over and invite his panelists. And I am been told Dr. Gurvinder is unable to join, so I think rest of the panelists will be there. So Dr. Sachin.
Yeah, thank you, Kunal.
Good evening.
Thank you for organizing this wonderful meeting, and I've been listening to the excellent talks already. So without wasting more time, I think we should go ahead with the agenda. We are already running nearly 15 minutes late for this, right? So you give me full time, or you cut my moderation now?
Depends on how much
How I
you
moderate?
want to discuss. Yes.
Okay. So I'll invite my panelists. I see Dr. Akanksha is there. Akanksha, Dr. Ketan, Dr.
Hi, sir. Good
Parikshit.
evening.
Yeah, good evening. Dr.
Good evening,
Hakim
sir.
Ansar.
Yeah, good evening, everybody.
And Dr. Nitish and Dr.
Hello,
Kunal
sir.
Dhal.
Yes, good
Is
evening, sir.
Kunal there?
He's the
Yes,
lone
sir.
surgeon.
Kunal is surgeon, right?
Yes, sir.
Yeah. Great. So we'll have one surgeon and a lot of medical oncologists. That's the usual way we, do our panel discussions. So let me share my screen. Can you see my slides? Yeah. Okay.
Not yet. It is.
I think वो stop sharing करना पड़ेगा बाकी देखना. Is somebody else sharing? Now you can see.
Yes.
Yeah. Okay, so this is about evolving treatment paradigm in endometrial cancer. So after conquering lung cancer space and many other malignancies, so immunotherapy is entering the endometrial cancer also in a big way. And so this is a GSK sponsored session. And okay, so we know a lack of innovation has created disparities in outcomes for advanced recurrent endometrial cancers. And for advanced and recurrent EC, the prognosis is still dismal, right? For if the patient is having stage 4 and distant metastasis, outcomes are still not good, but they are gradually improving with the treatments. So I'd like to ask Dr. Kangsha, what is her go-to regimen till now, before the advent of immunotherapy? What chemotherapy drugs she would use for advanced and metastatic endometrial cancer?
So basically, for stage 3, my go-to regimen is POTEC 3 trial, where I would go with the CTRT first with cisplatin, followed by 4 cycles of paclitaxel plus carboplatin-based chemotherapy. This is my go-to regimen.
Right, and for stage 4?
Sir, basically I use paclicarbo only. My chemo backbone will be same, but then rest depends on
Patient
the
status
biomarkers which we have.
and
Yes.
biomarkers. Dr. Ketan, are you comfortable with let's say if CTRT first followed by chemotherapy 4 cycles, or do you do the reverse also sometimes? Some patients don't tolerate chemotherapy later on after pelvic radiation. Do you also feel so, or you follow
Yes, sir.
POTEC as such, as
Yes, sir. In fact, I strongly feel so that the tolerance after pelvic RT falls uh, drastically. In fact,
so
myself,
sometimes you reverse also.
yeah, I agree.
Okay, so let's move ahead. So now this carboplatin and paclitaxel, this provides improved outcomes. So this we know that improved outcomes are there, but long-term outcomes are still poor. If you look at the median OS in these, with chemotherapy regimes, so again they are very great. So we still need much more to do. And so what do you do after this? So Dr. Hakim, your patient has received paclitaxel carboplatin and has relapsed. So before advent of immunotherapy, what would what were you using before that, and what were the outcomes like?
As you know, before the advent of this immunotherapy, there were very limited options available. So I will go again with some second line agent, and the outcomes were very poor.
So what second line agents you have been using in such scenarios?
Again, gemcitabine, docetaxel, and other drugs.
So see, okay. So we have various drugs. Dr. Nitish, what are your go-to regimes after Pecli Carbo?
It depends upon what is the duration I have achieved with the paclitaxel carboplatin. So if
Yeah.
it is more than 12 months, I'm still okay to re-challenge sometimes a patient with the paclitaxel with carboplatin, or otherwise there are various drugs which have shown almost the same benefit. Like I can try a nab paclitaxel based combination, then docetaxel is another.
Okay, yeah, right. So this slide
Gemcitabine and
shows some of the
liposomal.
drugs. Yeah, some of the drugs and the response rates. So if we look at this table in second line chemotherapy, majority of drugs are not even reaching double digit mark. That's how dismal the response rates are. So again, paclitaxel re-challenge is working, IFOS, Oxali, Exavipilon. So they are giving some double-digit response, but otherwise, majority of drugs are not giving much benefit here. So there's a huge unmet need, and so of course we need to improve here. And so this is the real-world evidence which reflects the poor outcomes seen with the current therapeutic options. So time to next therapy and the OS. So all these parameters are quite dismal in advanced endometrial cancer. So now it's the time of biomarkers. So we have been doing biomarkers for a lot of malignancies and so for even in uterine cancer as well. Dr. Parikshit, what are your choices of biomarkers? So let's say, okay, I'll give you two situations. So one, you have a patient who
Okay,
has got early stage, let's say a stage 1 operated by Dr. Kunal, and patient comes to you, endometrioid stage 1. So what are you going to order for this patient, and what are you going to order for a stage 3 and 4?
So for a stage one, the important biomarker, what I'm looking is for a P53 mutation. So for this
Okay.
patient, I will emphasize on a P53 mutation, what is that, testing to be done by IHC. So that is absolute. And for the next patient, as you said, for stage three, stage four, I would get the entire, panel, tested, P53, MSI by IHC, and POL.
And pool. So for advanced, you are ordering everything, but for stage 1 only P53.
So more or less, because this is a very limited subset of patients which we get. But usually, what we see
So
is that
nowadays we are getting a lot of stage 1.
Mhm.
So because endometrial cancer still presents early because bleeding happens and patient is alerted, postmenopausal bleeding is a very alarming symptom. So we do get Dr. Ketan, would you agree? Are you getting stage 1? Can you hear me?
Yes, sir. Yes.
Something
I think
happened in between, no?
I think
There is
some
some
network issues
network.
probably.
Sir, can we repeat that answer for biomarkers in stage 1?
So yeah, so for stage 1, so we are still discussing, Dr. Ketan.
Right.
Asking you that are you getting a lot of stage 1 patients or not?
Yes, sir. Quite a few stage 1
Yeah,
patients, early
yeah.
stage
So we have
endometrium.
stage
Yeah,
1 patients.
yeah.
Yeah.
Endometrium CA presents quite early with bleeding. So
Mm-hmm.
we often get stage 1 and
Very,
2 patients.
very
Yeah.
often you get that.
Yes, yes. And in
So,
fact, yeah,
hmm
we do a TP50,
so
P53
yeah.
poll and MMR testing. Now we have
So
an
we are, so
algorithm.
you're doing this for all your patients, right?
Yes, sir. Yes, sir. Because
Not only
they,
for,
yeah.
right? So
Sir,
this
this
is
is
the
only for early
algorithm.
stage. Sorry.
Yeah. So early and advanced. So for advanced also we need to see, look, you're anyway going to treat advanced stage patients, right? So
Yes.
their MMR, HER2 and other things are more important. They would help you to take more decisions. But we know from ESCO clinical practice guidelines, so we are doing pole status. Pole is a good mutation, right?
Yes.
And so if it is not there, if it is wild type, we look for MMR. And if deficient MMR is there, or if it is not there, then we look for P53. And this is the prognostication here. So P53 abnormalities you're going to find in nearly 15-20% patients, and they of course have poor prognosis. And once you find this, you tend to offer adjuvant treatment to even early stage patients, right?
Yes.
And for deficient MMR, it's intermediate prognosis, and pole is a good prognosis, but the percentage is less. And then there can be non-specific molecular profile, which again has a intermediate prognosis. So I think most of us are ordering this test for early stage patients to prognosticate our patients, right?
Yes, sir.
So one comment
Did you
here.
have anything to add here regarding the mutations you would order?
So basically, if in early stage, if it is P53 positive, then we are going for the chemotherapy because we know it's a poor prognosis. That is the only thing. Otherwise, yes, we are ordering all these three.
Yeah, so we have panels also these days. So all
Yes.
these tests are done together in a panel as well. Dr. Hakim, you're doing the same thing, or your practice
Yeah,
is somewhat different?
I'm doing at least these three markers, MMR,
Mm-hmm.
P53, and pole in early stage also. Because by pole also you can I mean de-escalate treatment. You can reduce the intensity of treatment if it is there.
So,
Sir, may I have a comment here, please?
yeah.
Yeah. So with pole, I think, like Dr. Hakim said, that we can reduce the treatment de-escalation of radiation can be done if it is stage one, grade two, or stage two, not in usually not in stage three. And another point is IHC, doing only IHC for P53. I don't think that is going to suffice for CA endometrium because most of our patients are going to have IHC positive, even if it is endometrioid and some of the serous endometrial carcinoma also. So molecular mutations are to be tested in a molecular fashion only. I'm not sure what is the correlance, the correlation between IHC and the P53 testing on the molecular platform.
I think we can look for this. Dr. Akanksha, why don't you search and let us know while we are discussing?
Sure, sir, sure.
Yeah, we can answer this question right away. Even I'm not sure about the concordance here. And so meanwhile, so we know that MSI and deficient MMR, so the chances of getting this are higher in endometrial cancer. This is one malignancy where you would get a lot of DMMR. And so would you put any percentage here? Dr. Kunal, are you ordering this test yourself or you're passing on to medical oncologists for this?
Yes, sir, we do order these tests for the affording patient because
Yeah.
code is
So how much
not available
percentage
for
of
every patient.
this deficient MMR do you encounter?
Roughly from 15 to 20%.
Yeah, so it's pretty high, and so nearly 20% of patient, and maybe beyond also. So that also depends upon the histology. So if you have, let's say, endometrioid, the chances of getting this DMMR is even higher. So it may be less in, let's say, serous or clear cell, but endometrioid is one area, and where the chances of DMMR is higher. So this would depend upon the histology as well. So let's go to this case scenario. It's a 62-year female, postmenopausal, and she's a hypertensive lady, and she presented with postmenopausal bleeding and had bulky uterus with some parametrial stranding suspected, and imaging showed a large endometrial mass extending into parametrium and involvement of cervix and bilateral pelvic lymph nodes. So they were large nodes as well. And so this patient was operated and she had endometrioid grade 3, MMR proficient, ERPR negative, HER also negative, and pole and T53 are also, TP53 is also negative. So she falls into FIGO stage 3C1 with pelvic nodal involvement and no distant meds. And a debulking surgery has been done. So now what are you going to do? Do we follow some? So this patient, so I give you two scenarios. So she has no residual disease versus she has some residual disease. So what would be your go-to regime here? Dr. Akanksha, are you ready with your search? You can
Sir,
first
I
tell
have
and then
just
give.
searched with that, and the search says that we have a paper which shows that there is good concordance of P53 with IHC and NGS.
So you need not repeat with NGS if ISC is showing positive or mutation is there.
As per the research which I have done just in 5 minutes. Yeah.
Okay, fine. Okay, so you take up this question. So you have a stage 3C1, FIGO 3C1 endometrioid, and so debulking surgery done with no residual disease versus residual disease. So what are you going to do in the adjuvant setting?
Sir, till now I have been using POTEC 3 only, but we have data now with both with residual and non-residual disease where we can use immunotherapy like pembrolizumab and dostarlimab. So different settings have different means they have included the patients with in pembrolizumab there was no residual disease in such patients, whereas in dostarlimab data that can be given even in patients with the residual as well as non-residual disease. So that is something that to be pondered upon. But as of now, I have been only using POTEC 3.
Okay. Dr. Parikshit, what is your choice? In Ruby trial, the inclusion criteria said patient who have measurable residual disease. I think that was the inclusion criteria.
Yes, sir.
For dostarlimab.
Yeah.
Okay, then you are taking up?
Yes, sir. So actually, the trial in which there was no residual disease after surgery. So these are very important distinctions, as you have clearly pointed out. So the Pembro trial, I think, was not positive trial in which there was no residual disease. The only trial that we have positive after POTEC 3 with residual disease is with dostarlimab. Please correct me if I'm wrong. This is the impression that I have as of now. So yeah, in patients with residual disease, dostarli plus chemotherapy would be my go-to choice.
Okay, and Dr. Parikshit?
Sir, could you repeat the question, please?
So you have a stage 3C1 patient operated. So patient had large pelvic nodes and a debulking surgery has been done. And of course, you are going to use radiation also in this patient. I won't go deeply into the radiation part of it. But for chemotherapy part, what are you going to do? If the patient is having some residual disease, measurable disease, what is your choice of treatment versus no residual disease?
If there's any residual, disease, I will more likely, go for, dostarlimab, sir.
If there is
residual disease,
then you will go for immunotherapy, dostarlimab based.
Yes,
Okay,
sir.
and if it is fully, let's say, debulked,
Completely debulk,
then
sir, I would, I would stick to only chemo-based
POTEC
treatments.
only. So, Dr. Hakim, is that your practice as
Yeah,
well?
I would like to add something here.
Yep.
When we look at the inclusion criteria of the Ruby trial, is
Yep.
mentioned that for endometrioid carcinomas, you have to look for this measurable disease. If there is measurable disease,
So that is
then
there in the
you
inclusion criteria.
yeah. But if there is any other histology like serous, clear cell, or mixed in carcinosarcomas, there may not be measurable disease, and you can give this regime.
So, Dr. Nitish?
Yes, sir. So I think first we need to define what is measurable disease. The thing is, from ovary, we have taken this definition of more than 1 centimeter as a residual disease. We know these patients are not going to do well. So, if a patient can be operated again, though that is not going to be the chance for the patient, if there is a single lymph node which is remaining in the para-aortic area or somewhere in the abdomen, if can be operated, I would like my surgeon to go ahead and do a repeat surgery, clear the lymph nodes, and then I would like to start the adjuvant therapy. And that
So
adjuvant therapy.
no, I don't get it. So patient has come to you, your surgeon has sent you, Dr. Kunal has operated and he's
Mhm.
done surgical debulking. Now
Right.
he is sending the patient to you. And so
Mhm.
let Kunal come here.
Yes.
Kunal, how would you tell your medical oncologist that what is the level of surgery you have done and whether there is some residual disease there or not?
Sir, residual disease, if it is there, it is because it is inoperable or it is unresectable. We
Okay.
then there is no point going in again
Going.
and doing the surgery again.
Okay.
So
So then that could
I will
have
never
been
So what could
consider
be
decided
this
the
patient.
upfront or
scenarios where, a repeat surgery we would consider in such a patient? Is there any such scenario?
Uh, uh, I haven't come across much in such a scenario, but in the future, if there is a if there is good response to chemotherapy, and if it is an oligo kind of only single lesion is there that is image wise resectable, then we can take a chance. Otherwise, after surgery, going for a second surgery in the same before going for chemo, I will not do that.
May
so,
not be a great idea.
so the
Hmm.
reason for residual disease I would like to know, because we need to prognosticate these patients that it is not a good disease to have if we are having a residual disease. That is one thing, sir. And if there is a residual disease, I would actually like to add immunotherapy along with the chemotherapy.
Yeah. So that's how the trials have been done. So for especially the Ruby trial, for measurable disease, you tend to add immunotherapy to chemotherapy. Let's just discuss some of the data here in slides. Okay, so these are the current NCCN guidelines. So for stage 3 and 4, so pembrolizumab can be used for except for carcinosarcoma. Dostarlimab based for all the patients is a category 1 recommendation as well. Durvalumab is also there. And if it is HER2 positive, then you can consider trastuzumab here. And okay, so now we have a lot of choice here. So as we saw in this NCCN guidelines, so we have pembrolizumab, we have dostarlimab, we have durvalumab, and we have PARP inhibitors. Some of these patients would be harboring some hereditary mutations, and also could be HRD positive as well. So how do you choose? Look, what drugs have to be given? Dr. Akanksha, you go first. So you have, three choices here now.
Sir, we have this NRG trial for pembrolizumab. We have this trial for dostarlimab, as well as the Duo-E trial with durvalumab,
We,
which is only for deficient MMR. But if you look at the data, the most impressive data which I found was with dostarlimab. So that would be my preferred choice.
so would you like to qualify, like, look, if we look at DMMR group, all drugs are giving good,
Uh,
hazard ratios.
sir,
Dr.
kindly
But sir,
Ketan, would you
hazard,
like to come here?
hazard ratio?
yes, sir. Yes, sir.
Yeah.
So I would assess the patient for any contraindications to checkpoint inhibitors. Let's say if there are none, then I would also look
Mhm.
at the HER2 positivity because
So
in
patient is
case,
HER2 negative and
yeah,
patient is fit and fine. So you have to choose. So there are two scenarios. One is deficient MMR and the other is proficient MMR. So I give you
right,
these
sir.
two scenarios.
Right, sir. Sir,
How do you go about it?
in deficient MMR, I think the results of both uh, all these checkpoint inhibitors are par excellence. So, coming to the proficient part, I think although we should not do cross trial comparisons as we always, but we tend to do, I think the data for Ruby is quite strong in that scenario.
Okay, Dr. Parikshit, what is your take on this?
So I would agree with Dr. Ketan. The data for dostarlimab, you know, across the setting is the strongest, and especially if you compare the PFS rates with dostarlimab, I think among the IO regimens we have the highest PFS rate with dostarlimab.
Hmm? Okay, Dr. Kunal, how much time do we have for this?
So last 5 minutes, sir.
We are
Five
just
minutes.
on the
Okay, I'll
borrowed
just go
time.
through some data as well. So this is a schema of Ruby trial. So stage 3 and 4 or disease or first recurrent EC with low potential for cure by radiation or surgery alone in combination. So this could be carcinosarcoma, clear cell serous or mixed histology, So all these patients were taken into account, and dostarlimab with chemo and followed by maintenance dostarlimab. So these were the and endpoints were PFS and OS. And if we look at so majority of these patients had some measurable disease at baseline. So if we look, this is nearly 90% and above. And so these are the histologies. So mainly endometrioid, and but some of these patients could be carcinosarcoma, mixed, serous, but there were hardly any clear cell and mucinous. Right? So carcinosarcoma. So this is the deficient MMR group, and if we look the hazard ratio, so this is the PFS, and so these curves are quite impressive here. 72% risk reduction. Okay. Okay, and this is the proficient MMR group. So here the hazard ratio is 0.76. And if you look the median PFS 9.9 versus 7.9. And in the previous slide, it was not reached versus 7.7. So of course, DMMR group is benefiting a lot. And this is the PFS by as per investigators, overall population hazard ratio 0.64. So again, impressive. It is doing much better than your only chemotherapy arm. And this is the updated OS. Risk of death reduced by 31%. So this is despite a higher proportion of patients in the chemo arm receiving subsequent IO drugs. So the crossover was there, but still the patients who received IO upfront and in combination were doing better. And this is the updated OS, and hazard ratio 0.32. So this is for the deficient group, and this is the updated OS for the overall, for the proficient. Okay, so I'll just go through this. So the PFS2 is also better and meaningful in this population. Okay, let me just get the gist of this case. So now this patient is a recurrent disease. So patient has underwent hysterectomy. So a surgery has been done, proficient MMR, and received chemoradiation and post-surgery. Now DFS of 3 years and recurred in liver and some nodal disease. And this was an endometrioid. So what would be your choice in such a case here? Dr. Parikshit, you can go first. So recurrent disease treated with chemo RT upfront 3 years back.
So because this patient, has a long, DFI of approximately 3 years, I would go ahead and, rechallenge with, paclitaxel plus carbo for this,
and IO
patient.
And you would add IO
And
here?
with reference to the, yes, sir, I would like to add IO. I would like, to get a rebiopsy done from the, from the liver lesion and to send, what is it, across an NGS for this patient.
Do you recheck MMR here?
Yes, sir.
Sorry for the interruption. Kindly conclude.
Yeah. Okay, so I just like to highlight this point that sometimes the proficient MMR may become a deficient MMR at recurrence. So this can also happen. So if there is a good gap in the in the recurrence, we can do a rebiopsy and should check for biomarkers again. So that's how things can be better. And so these patients are more likely to respond better to the IO drugs. And that's how we can prognosticate better for these patients. I think we can conclude here since we have lack of time. And thank you all the panelists for their inputs. And
Welcome, sir.
I hand over to Dr. Kunal for further sessions. Thank you, everybody.
Thank you. Thank you, Dr. Sachin, for moderating this session. I understand there are still few unanswered questions which we can leave for the next meeting. And the duration of immuno may also be important. Dostarlimab has to be given for 3 years, where the
3
other are
years.
2 years or less. So that also we have to keep in mind. Okay, so we move to the next panel discussion of ovarian cancer, and for that I request Dr. Chitresh to please take over.
Good evening, all. Are my slides visible?
Yes, they are visible to be put on slide show mode.
Are they okay now?
Great.
So I welcome all the panelists. I will request Kunal sir to please name the panelists and
Sure. So
I don't
I'll
have the. Yeah.
so Dr. Javed Muzammil, Dr. Satyankar,
Yes,
Dr.
sir, available.
So
Good evening. Good evening.
good evening. So full J&K team is there. Then Dr. Navdeep from AY Jalandhar, and Dr. Shuchita, I think she is not joining. So you have four people. Is Dr. Navdeep there?
Yes, sir, I'm here, sir.
Okay, great. Great, Navdeep. Dr. Ulfat?
Yes, yes.
Okay, great. So four people are there, Chitresh.
Okay, sir. So this is the current landscape of PARP inhibitor approvals in ovarian cancer. We all are well aware of these. So three drugs primarily: niraparib, olaparib, and rucaparib. So I think as we go in the further slides, subsequent slides, we will see the evidence to use each of them. So first line maintenance for a patient who is BRCA mutant, we have the approvals to use all three. For wild type, we have to use olaparib with bevacizumab and with proficient HR. We have to see in subsequent slides. So this is the PFS benefit that we see for patients who are BRCA mutant, who are HR deficient, who are HR proficient. So we see here that the magnitude of benefit is obviously more for patients who are BRCA mutant and HR deficient in comparison to patients who are HR proficient. So coming directly to the case one, that is 50-year-old female who presented with progressive abdominal discomfort and bloating, as well as early satiety, new onset constipation, and unintentional weight loss. She was healthy with a ECOG of 1, under hypertensive drugs for 10 years. Ultrasound abdomen revealed a 4.5 centimeters ovarian mass. On imaging, a PET scan was done, which revealed peritoneal metastasis beyond pelvis. METS was observed in, the retroperitoneal lymph nodes, and biopsy was done, which was suggestive of a high-grade serous ovarian cancer. So the staging based on the tumor presentation is 3C. So how do you approach this case first, and what to do? Anybody can start, and Dr. Javed sir, will start with you.
Yeah, hi, Chitresh. So this is a stage 3C clinically, as far as the staging is concerned. Looking at the whether we go for the cytoreductive surgery first or a neoadjuvant chemotherapy, that's a question where the tumor board will decide, where the surgical oncologist will be in board, and who will say that yes, I can achieve the optimal cytoreduction or not. If optimal cytoreduction is not achieved by him, and definitely we will go for the NSCT. But otherwise, also what we see in our clinical practice, patient presenting with abdominal disease, disease above the ligament of trees, diaphragmatic deposits, stage 3 disease with nodal involvement as well. We prefer to go for the neoadjuvant chemotherapy. So those are the where the we or the surgical oncologist in the team says that proper cytoreduction is not possible and optimal is not possible. So definitely we will go for the neoadjuvant chemotherapy, and that too again for a patient having serous type of the high grade adenocarcinoma.
So, Dr. Satyankar, patient was discussed in the multidisciplinary tumor board and was decided to subject to neoadjuvant chemotherapy. So, how do you use bevacizumab in this setting? You use for all your patients, or you have a set criteria to offer or not to offer bevacizumab in neoadjuvant setting?
So only I have to look up to the relative or contraindications for bevacizumab, on where I suspect possibilities of GI perforation and uncontrolled hypertension. Otherwise, I prefer to use bevacizumab in a lot of my patients, especially for the first two cycles and not for the third one.
Dr. Ulfat, any difference of opinion there, or you agree to this?
So basically, in adjuvant setting, if we have to use the BEV, then it should be stage 4 disease. It should be serous effusion, that's presence of ascites, and incomplete cytoreduction achieved in stage 3 disease. As far as neoadjuvant chemo is concerned, it has not shown any OS or PFS benefit, except that in stage 3, it may improve the complete cytoreductive rates and response rates, but no OS or PFS benefit as compared to the adjuvant treatment.
So, will you offer neoadjuvant bevacizumab to this patient or not?
That's what I'm saying, that in this patient stage 3C, if we are suspecting that it may undergo, we have to give, if we are offering this in a neoadjuvant setting, then the benefit is plus minus.
Dr. Navdeep?
Yes, sir, I agree. In the neoadjuvant setting, normally I don't use, but yes, if the patient is having some massive ascites, poor symptom control, or any some unresectable disease where Down's staging is critical and there is no bowel involvement. And important point is again that there should be strict washout before surgery, a minimum of 6 weeks. Yeah, in few cases I would like to use, but not in every case, sir.
Okay, so I think the panel, the consensus is that for a heavy burden disease, advanced stage leukemia, so for tumors which require, something more than chemotherapy for response, and for urgent, debulking tumor size, we would offer bevacizumab. Otherwise, neoadjuvant chemotherapy alone is also not bad option. So, which biomarkers do you use in ovarian cancer patients? What biomarkers do you order, and when do you order those? And Dr. Javed?
Except for the tumor markers, what we ask for both CEA and CA125, and the biomarkers, what we ask for, upfront a patient who will go for the neoadjuvant chemotherapy, definitely nowadays biopsy is to be done. Earlier on, we just relied on ascitic fluid cytology, M cells present, and we were giving the patient neoadjuvant chemotherapy. And nowadays, biopsy is not only mandated for confirmation also, but it will tell you about the histopathologies and high grade serous, or it is some clear cell or something else. And second, it will you will be using that biopsy for HRD testing. You will be using it for the BRCA somatic as well as the germline. So what I do in my practice, getting the biopsy and send the biopsy for somatic as well as the germline. First somatic, if it is positive, then reflex testing for the germline BRCA testing, and HRD as well. So if HRD has come positive, so they definitely will say there as well that the BRCA is mutated or not, and give you other genomic scoring as well. So these things, not complete CGP. We don't go for the comprehensive testing, but these two, because these will guide us for further treatment in the adjuvant setting as well as a maintenance also.
Dr. Satyankar, what is your practice? What do you do day in and day out in your practice?
Yeah, tumor markers, HRD testing, plus minus additional germline BRCA testing, because I have few patients who were HRD, negative. Somatic BRCA was negative, but germline turned out to be positive. So I would do a germline BRCA also, and in the upfront setting.
Dr. Ulfat?
Dr.
Sir, in
Satyankar, I
practice,
think it is very uncommon that
Uncommon. Yes, it is. It
very
is.
uncommon.
It is.
Somatic is The positive and germline. This somatic is
So what is
negative and
negative and
germline
germline is positive?
very
It
uncommon.
is very uncommon. And the
But
patient
that
has
is very
responded.
uncommon scenario. Yes.
Yeah. But the patient has responded.
Practically,
Yeah,
practically
Dr.
speaking,
Ulpati
it
would.
is so right that we have with somatic and then with germline. But we know that comprehensive genomic profiling covers the other mutations as well. But in clinical practice, we usually don't offer it upfront.
Dr. Kunal, you wanted to say something?
Nothing in specific, but again, as Satyankar himself mentioned and Dr. Javed, because somebody with a somatic usually covers. If once it is negative, generally I don't
The
tend to.
germline is also, yeah.
Yes, so but occasionally I don't know the testing methodology or something. What is the problem?
So moving on, so I think the consensus is that these patients nowadays, after the biopsy, if you're giving neoadjuvant therapy, most of them are doing the somatic BRCA, then the HRD testing, and as we discussed that if somatic BRCA is negative, generally we do not get a germline BRCA positive, but on a case-to-case basis, as Dr. Satyankar mentioned, that based on some testing error or the technique that they are using, there could be some differences that we can see from lab to lab. So this patient that we are talking of underwent germline BRCA testing and HRD testing from a lab developed test in India. Germline BRCA1 to negative, HRD positive with a genomic scar of 65. So what do you do now? Again, Dr. Javed.
Yes, I
So
think it is sufficient test for us that will guide us for the treatment. I think neoadjuvant treatment has been given, or we have just started.
So this is just the testing that we have done, and this is the information that is with us, and we have to offer a neoadjuvant therapy to this patient.
Fine. Since this patient had massive ascites, stage 3C disease, and she had a serous type histology as well, I would consider giving bevacizumab for the 2 cycles of bevacizumab and or 3 cycles followed by 4th cycle. I will not give bevacizumab with paclitaxel, followed by the surgery, and then after surgery 1 cycle we will miss bevacizumab again, and then continue complete 2 cycles further. So paclitaxel 6 cycles perioperative. Then since HRD is positive, so I have 2 options to these PARP inhibitors. Either I will choose the Pavlov pathway, or I will choose the this Prima pathway. So in both ways, you can give the PARP maintenance for 2 to 3 years. It depends upon whether you have used the niraparib or you have used the olaparib.
So I think this is what guidelines also tell us, that patients who are not candidates for upfront surgery, we have to do the germline and the HRD status. Then we have to offer them neoadjuvant therapy, interval cytoreduction, and then after the cytoreduction and the chemotherapy adjuvant setting is over, we have to see the BRCA and the HRD status, and then either we have to do the Paola pathway or the only PARP inhibitor pathway that we all discussed just now. So primary cytoreductive surgery, no residual disease, platinum doublet, 6 cycles. Bevacizumab in this case was not given due to hypertension. Patient had partial response to platinum. Choice for maintenance therapy, as you mentioned, it is a BRCA negative HRD positive. So this is the median PFS that we see in BRCA negative HRD positive patients. We do only GOG 218. We have a very minimal advantage of 16 versus 10 months. With Paula 1, the combination 30 months. For prime, it is 19 versus 10 months. So this is the subgroup that we are talking of. So we have to always keep in mind that this is not a very comfortable drug to tolerate, and the discontinuation rates due to side effects and adverse events, they are quite high. And the maximum damage is actually the Paula one, because we are using 2 side effect causing drugs, that is bevacizumab and the olaparib. So I would like to ask your individual clinical practices that what is your go-to regimen in the adjuvant setting, and what difficulties do you guys face, while maintaining these patients in the maintenance phase for 2 years or 3 years? Dr. Javed, and then subsequently Dr. Satya.
Yes, if I have, this combination of bevacizumab and olaparib, I think I have completed few patients the full course, and only in between I had to stop because of the toxicity of the olaparib, not because of the bevacizumab. Yes, two adds, the toxicity also gets added up, hypothyroidism, hypertension. Only the perfusion is the problem, which is difficult to manage. Niraparib, not used it so far. Rucaparib also used, but the dose we are not giving it up to optimum like 1200. I have never crossed 800 milligrams of Rucaparib. And similarly, I have not crossed in any patient olaparib more than 450 per day. So 600 not given. So some single monotherapy also olaparib I have stopped in between because of the toxicity, severe anemia, some patients, and some patients had diarrhea. Some patients had severe fatigue as well. So the most of the doses are between 300 to 450, and the combination with bevacizumab, very few completed the full course of combination maintenance.
Dr. Navdeep.
Yes, sir. So not use combination in much, but yes, use PARP inhibitor. Yes, again, the same similar side effects with olaparib, commonly anemias and all thrombocytopenia that I faced, but not use combination specifically.
Dr. Satyankar.
Sir, I have used in quite a significant number of patients the combination. Bevacizumab 15 milligram per kg is well tolerated, but yes, the dose of PARP inhibitors I have used Ola and Ruka have not been more than 75%. Exactly what Dr. Javed has said.
Okay, so this is a GSK meeting. So in niraparib, 200 milligram OD was initiated. But in your practical experience, have anybody used niraparib, and how is the experience so far? Anybody can take this. Dr. Satyankar or Dr. Javed.
I have not used it niraparib yet.
Dr. Kunal, your input?
Not used. I think that's why we are all here.
Correct. So I think the message is that this is a new
Education,
drug.
education. They are educating us.
Yeah. So moving on to the next case, this is a 60-year-old female presented with abdominal pain, bloating, and weight loss. No history of malignancy, no family history of malignancies. CT scan revealed a large mass in bilateral ovarian tissues. Multiple masses were observed on both sides of the pelvis, and the largest cross section measuring 7 into 6 centimeters. Multiple masses were also observed in peritoneum and omentum. CA125, 486 elevated, laparoscopic biopsy, high-grade serous carcinoma. Patient 4B, high-grade serous carcinoma. So obviously, this is an ideal candidate for a neoadjuvant setting. I will not waste time on this. So patient received neoadjuvant paclicarbo 3 cycles. Interval debulking was done, and post-surgery adjuvant paclicarbo was given. Molecular testing BRCA negative and HR proficient. So for a patient who is BRCA negative and HR proficient, what is your go-to maintenance therapy, and how do you manage your patients? Dr. Ulfat?
Sir, if we have given Bev in the primary treatment arm and patient is HR proficient, then we go with bevacizumab. If we have not given, the only PARP inhibitor that seems to be feasible is niraparib in HR proficient, though I have practically not used it.
Dr. Javed?
Yes, what Dr. Ulfat has already said, in HR proficient, we don't have many things to offer except bevacizumab and niraparib. Since we don't have niraparib experience yet, yes, that's the option that we can use. In HR proficient also, rucaparib had some advantage. I have used in some, but had to stop it because of the disease progression.
Correct. So I think niraparib, the new drug, has a role, a very important role in this population, because it has some negative and HRD proficient. They respond well to the niraparib. So, a 58-year-old woman diagnosed as stage 3C high-grade serous ovarian cancer underwent neoadjuvant followed by interval debulking surgery with R0 disease, achieved a PR, HRD positive, BRCA wild type. So, for such patients, what is your maintenance choice? If we go through the data which is available, so we have to see the differences in patient characteristics that is critical to interpret the outcomes, which is across the PARP inhibitor studies. And we have to see that there are certain group of patients who had high risk patients and technically certain studies which did not have any high risk patient. So, the PRIMA trial, as we know, it had the maximum number of BRCA wild type patients. And for solo one, there was no BRCA1 positive patient. And stage 4 disease, the maximum number of patients that were included were in PRIMA trial. And, the good risk patients were more in the solo one and the Athena mono trial. Now, a significant proportion of patients had no residual disease after PCS across the PARP inhibitor clinical trials, and be it the solo one, the Paola one, and the Athena mono. But a significant proportion of patients had also, no residual disease after the primary cytoreductive surgery in these trials. So what this data demonstrates is that there is potential for first-line PARP inhibitor maintenance in the setting of PCS, which is R0, and there is the PFS in the intention to treat population is definitely better with the usage of PARP inhibitors in this group of patients. So niraparib in patients with no residual activity after disease after primary surgery, the MITO40 study shows that it works really well, and the median PFS is yet not reached, in patients with no residual disease after primary surgery. So a very pertinent question is that do all PARP inhibitors work the same way, or if you keep aside the guidelines, do you think that niraparib, olaparib, and rucaparib basically are the same drugs, or these are three different drugs and they work differently on patient-to-patient basis? Dr. Javed.
I think for us, PARP inhibitor means PARP inhibitor, and we don't look at those things. But yes, individually looking at the different drugs, yes, pharmacokinetic profile is slightly different, and drug-drug interactions are different. Or as per the niraparib toxicity and niraparib pharmacokinetic is concerned, it's one of the innate drug. You don't have to think much what patient is on, what he should be on. So Nira is the go-to drug in that very scenario. But for us, PARP work in the same way.
Correct. So I think PARP inhibitors technically for us they are same. We choose depending on the side effect profile, the cost, the assistance, the tolerability, issues, and BRCA status in some subgroup of patients. So there is some pharmacokinetic activity difference in niraparib and olaparib. It is definitely higher in tumor pharmacokinetic concentration with olaparib and niraparib, and the primary and secondary targets, more targeted action with niraparib seen here. And so coming to the last part of it, that what are the precautions which are particularly related to drug-drug interactions you follow before initiating a PARP inhibitor therapy? Dr. Satyankar?
Mainly is the tolerability and drug-drug interactions. Yes, niraparib is an enzyme inducer, I think, cytochrome pathway inducer. But particularly, remembering all those drug-drug interactions is not possible. We just look into the various drugs the patient is already taking, like AKT, ATTs, or some, long-acting drugs. So otherwise, yes.
Correct. So I think the most potent inducer is olaparib, and out of all the PARP inhibitors, the minimal drug-to-drug interaction potential is actually with niraparib. This is what the chart shows. But
Yes.
Again, as you rightly said, that it is very difficult to remember all these interactions, and on a case-to-case basis, we decide that what is to be done. So to conclude, I think PARP inhibitors, they're an important part of the treatment now. Niraparib is the new kid on the block, and it can be used irrespective of the BRCA status and the HRD status. And with a good assistance and a good cost, because olaparib now is very, very cheap and generic is available. So we have to choose our patients and offer, niraparib to those at least patients who are not BRCA mutant or not HRD deficient. Thank you.
Thank you very much.
You, Dr. Chitresh, and all the panelists. I think it's well summed up. When there are a lot of drugs, comparisons keep happening, and over the time, you will see some comparison which is favoring one over the other, like we are seeing with immunotherapy and with CDK4/6 inhibitors. Every company will come with their comparison, and we have to remember that this is for 3 year duration. 36 months is for the Prima trial. So, and if we have not used bevacizumab, I think this is one drug which we can use in both the settings. So thank you once again. And we move to the last session. We are running late. So uh, I request for Dr. Priyanshu to just uh, be the showstopper and finish the session on lung cancer with serplulimab.
Thank you, sir. A very good evening to all. And I request the organizers to kindly share the slides.
Yeah, hi. Daud, do we have the slides for presentation? Daud, Vishal?
Yes, sir. I'm sharing.
Yeah, please.
बस इसके बाद डिनर है, फटाफट करो.
Serplulimab, the new standard of care in lung cancer, we'll be discussing today. This session is sponsored by Intas. Next slide. So these are the outlines. Next. So we all know small cell lung cancer is divided into limited stage and extensive stage, and we have more of patients, approximately 2/3 coming in extensive stage. Next slide. So the outcomes in extensive stage have been usually dismal, with a median overall survival of less than 1 year. In the last almost 40 years, we have the almost a similar backbone of platinum plus etoposide, and with the advent of IO in small cell lung cancer, we had a survival benefit of approximately 3 to 4 months extra. Next slide. But there is still a huge unmet need in small cell lung cancer with respect to extensive stage. So serplulimab is a PD-1 receptor inhibitor with a differentiated mode of action. It has significant PD-1 internalization compared to pembrolizumab and nivolumab. We can see here in the graph here. The serplulimab internalization rates are pretty much higher, approximately reaching up to 25%. And also there's a preservation of CD28 mediated signal which restores T cell function. Serplulimab blocks co-clustering of CD28 with PD-1 during T cell activation better than pembrolizumab. Next slide. So there are pharmacodynamic changes here also. The mode of actions. Next slide. And the differential receptor binding. Serplulimab binds to both PDL1 as well as PDL2, leading to a better and complete pathway inhibition. So PD-1 blockade on T cell prevents interaction with both PDL1 and PDL2 on the surface of tumor cells. Anti-PDL1 agents interact with PDL1 only partially blocking this pathway, while additional blockade may elicit a more intense T cell activation, hence a stronger anti-tumor response, as seen with serplulimab. Next. So the approval status, DCGI approved it in June 2025 for first-line extensive stage SCLC. Next. So these were the landmark studies which led to its approval. The Astrum 005 study, sorry, it was a global phase 3 randomized double-blind placebo-controlled trial of patients with extensive stage SCLC, first line, randomized to serplulimab plus etoposide plus carboplatin versus placebo plus carboplatin plus etoposide. The dose here used is 4.5 milligram per kg. Every 3 weekly for up to 4 cycles, along with chemotherapy, and then maintenance every 3 weekly till disease progression or intolerable toxicity. Next slide. So the baseline characteristic, one distinctive feature of this trial was the Asian population was the dominant population, almost 70%. in this trial, which no other trial has shown. Brain metastasis again almost 12 to 15% in this trial. Next slide. So we compare it with the other landmark trial, the IM Power 133 and the Caspian trial of Atizo and Durva respectively. So the Asian population here again is pretty higher, almost 69% with Astrum, while only 17% with IM Power 133, and 15 almost 15% with Caspian. Next slide. So 2025 ASCO data, the end of study analysis showed that the median overall survival was significantly prolonged, 15.8 versus 11.1 months, serpolimab versus chemotherapy alone. And the delta OS is 4.7 months. And if you look at the 4-year OS data, 21.9% versus 7.2. So the proportion of patient alive at 4 years is almost 3 times compared to chemotherapy alone. And after a median follow-up of 42.4 months, the hazard ratio for OS was 0.60. Next slide. So there's a 40% risk in reduction of death with the addition of serpolimab to the chemotherapy backbone. Again, if you look at the updated OS in subgroups, both Asian and non-Asians are benefiting. And almost all the subgroups are benefiting with this. PDL1 expression we don't usually test, and irrespective of PDL1 expression, there is a benefit with the addition of serpolimab. Next. Now these are the updated safety results. If you look at the overall significant adverse events, they were almost similar, 37.5 versus 36.2. Immune-related adverse events were higher as expected with the addition of serpolimab, 37.8 versus 19.4. But majority of these were actually grade 1 and 2. So grade 3 or more adverse events were 34.2 versus 29.1. So not very significant. So the major side effects were, anemia, alopecia, decreased TLC, decreased ANC, decreased platelet count, then GI side effects as well as hyponatremia. Next slide. So serpolimab plus chemotherapy has achieved a 3-year OS rate of 24.6%, bringing extended survival benefit to extensive stage SCLC patients. If you look at the OS gain is 4.7, the highest among the 3 immunotherapies which are approved for SCLC. Again, the hazard ratios are also the best with serpolimab, 0.61 OS hazard ratio versus 0.76 and 0.71 for Atizo and Durva respectively. Next. So we all know ESMO, magnitude of clinical benefit scale, MCBS. Next slide. So it has a MCBS scoring of 4 on this ESMO scale. Next slide. Next. While the others have MCBS of 3 or lower. Next. So beyond ES, SCLC, there are various trials which are ongoing. The phase 3 trial of head-to-head study in SCLC versus Atizo, Astride and 200. Astride with the enrollment of 200 patients, and enrollment has been completed. Then along with CTRT in limited stage SCLC, and also in the new adjuvant or adjuvant setting along with chemotherapy. Next slide. Next slide. So in the squamous NSCLC, we have the Astrum 004. Next slide. In the first line setting, we have serpolimab plus chemotherapy. Next slide. For advanced squamous non-small cell lung cancer. Next slide, please. So again, in treatment naive stage 3B, 3C or 4 squamous NSCLC without any EGFR mutations or ALK-ROS1 rearrangement, and treatment naive, randomized 2:1 to serpolimab plus nab-paclitaxel plus carbo versus placebo plus nab-paclitaxel plus carbo, followed by maintenance serpolimab and placebo. Next slide. The primary endpoint was PFS. So the updated PFS, if you see, median PFS was significantly prolonged, 8.3 versus 5.7, and the hazard ratio of 0.55. Next. So almost all the subgroups are benefiting with respect to addition of serpolimab to the conventional chemotherapy. Next slide. Again, the median overall survival was again significantly prolonged. Median OS was 22.7 versus 18.2, a hazard ratio of 0.73. Next. To conclude about this trial, 31.1 months of follow-up, the addition of serplulimab to chemotherapy showed median OS at final analysis 22.7 versus 18.2, hazard ratio of 0.73, p-value was significant. Updated median PFS at OS final analysis was 8.3 versus 5.7, again a hazard ratio of 0.55. Next slide. Then again, the Astrum 002, which is in first line non-squamous and SCLC. Next. So this was the final analysis. Next. Again, a randomized double-blind multicentric phase 3 study. The Astrum. This was again in non-squamous and SCLC stage 3B, 3C, or 4. Which were unresectable or could not be treated with surgery or radiotherapy. No EGFR, ALK, or ROS mutations or rearrangements. No prior systemic therapy. So it had three groups: Group A, B, and C, with a combination of pemetrexed, carboplatin, plus HLX04, which is a kind of bevacizumab biosimilar, plus serplulimab, followed by maintenance of these drugs except for carboplatin. Similarly, Group B again serplulimab plus HLX04 plus HLX04 placebo plus carbo plus pemetrexed, followed by maintenance of the three drugs. Again, Group C serplulimab placebo plus HLX04 placebo plus carbo plus pemetrexed, again followed by similar maintenance without carboplatin. Next slide. So these are again the baseline demographic and disease characteristics which were well matched among the three groups. Next. Now coming to the overall survival, the addition of serplulimab to chemotherapy led to improved OS. If you look at the comparison with Group C, Group B has a median OS of 26.8 and Group A has 23.7 months of median OS. Next slide. Subgroup analysis, even patient with brain metastasis, they had an OS advantage, and the TPS more than 50% were benefiting the most when Group B was compared with Group C, and when Group A was compared with Group B, again uh, there is a benefit with respect to overall survival, mainly in the Group B patients. Next slide. So this was a BICR assessed PFS analysis. The median PFS in Group A 12 months, Group B 11 months, and Group C 5.7 months. So compared to Group C, both Group A and B are doing pretty well. And the p-value was significant for Group B, and the hazard ratio was 0.54. Next slide. Again, subgroup analysis similar to overall survival, brain mets and DPS more than 50% benefiting the most. Next. So these are the response rates. The confirmed ORRs were higher with almost double in Group A and Group B compared to Group C when serplulimab was added to chemotherapy. Next. So the addition of serplulimab to chemotherapy significantly improved OS and continued to confer improvements in other efficacy endpoints for treatment-naive patients with locally advanced or metastatic non-squamous and SCLC. The addition of bevacizumab to serplulimab plus chemotherapy did not demonstrate further statistically significant improvement in OS and other efficacy endpoints overall, as seen in that Group B, which had a placebo HLX04, had actually a better PFS and OS compared to Group A, which had the original HLX04. So both investigated treatment regimens had manageable safety profile. So the combination therapy of serplulimab and chemotherapy is an alternative first-line treatment options for a patient with locally advanced or metastatic NSCLC, non-squamous NSCLC. Adding bevacizumab to this combination did not confer additional survival or clinical benefit. Next. So this is a conclusion of our slides here. Serplulimab has a unique mechanism of action, including high PD1 binding affinity. PD-1 receptor endocytosis, and preservation of CD28 signaling, potentially explaining its enhanced T cell activation. Serplulimab has the highest ESMO MCBA score of 4 for extensive stage SCLC, indicating substantial clinical benefit. Serplulimab represents a new standard of care for first-line extensive stage SCLC. Beyond ESSCLC, serplulimab is approved in China for squamous NSCLC and non-squamous NSCLC based on robust data in phase 3 trials. Ongoing trial, that is H2H trial versus Atezo, and phase 3 in limited stage SCLC along with chemoradiotherapy. They will further add to the evidence of serplulimab in various lung cancer settings. Next slide. Thank you. So I think with respect to the available treatment options, serplulimab offers a good efficacy, much better costing, and a reasonable safety profile. So I think it's worth using at least in SCLC where it has a DCGI approval.
Thank you, Priyanshu. I think one of the USP for the drug is the cost, which is the least of all the immunotherapy drugs. So
yes, sir,
definitely is useful. So thank you very much.
Thank you, sir.
We are finishing about 26 minutes late. So I thank all the esteemed speakers, moderators, and panelists who have kept us engaged for the last 2 days, covering most of the aspects of breast cancer, lung cancer in detail, and bits about endometrial, ovarian, as well as urothelial cancer. And I would like to thank all the sponsors, especially Roche, AstraZeneca, Zydus, Astellas, Dr. Reddy's Sun, JSK, Cipla, and so many others who have helped us to make this webinar a success, and also the lab partners, MedGenome, as well as OneCell, and as well as Strand. And special mention for team from Horizon, Tarunji, and especially Vishal and Daud, whom have been coordinating all the for all the meetings and coordinating with all the speakers and panelists. So thank you once again, and good night. And is that all? Is Tarun there?
No, sir.
Okay. Good night. Thank you very
Good
much.
night, sir. Thank you.
Thank you, sir. Good night.